interesting enough, so I hope it should be okay. Looks like, let me see whether I'm trying to open up. Yes, there are two little things here. So, okay, let me just open up the first one. Okay, this afternoon I'm going to talk about the ethical and the legal issues. And as I mentioned, the biggest challenge with human tissue biobanking is really about people. So, what I'm going to deal with is I'm going to talk about not just the legal and ethical matters, but also some of the societal norms and societal issues that relate to human tissue banking that have an impact upon how we handle human tissue. Okay, the first one is about the scope. So I'm going to start off by talking about the structure of the biobank, the stakeholders involved, and the governance. I quickly mentioned that this morning. I'm going to talk a little bit more in detail about that. Then I'm going to talk about the legislation relating to human tissue biobanking. I recognize that not all countries have any legislation relating to human tissue biobanking. I'm going to talk about consent matters and material transfer agreements, privacy, confidentiality, return of incidental findings. In my second part of my talk, I will go into more details on legislation using Singapore as an example. And that's my last talk. And I also would like to share with you before I end a different model to biobanking, which may be a little bit controversial, but I will explain to you as we go along what that means. So let's look about the structure of the biobank. So first we think of the organizational structure. If you're going to start a biobank, we have to ask yourself the question, is this biobank going to be a national, institutional, or departmental asset? And that could be quite different. He who pays the piper calls the tune. So whoever is paying for that biobank will modify or rather have influence upon how the character of the biobank is. So is this going to be a national asset? And or is it going to be fully funded by the hospital, by the institution or the university, or is it just by the department? Who does it serve? And that comes into it. And therefore who funds the biobank? You could have a problem if it is going to be an institutional asset but funded by the government. Because the government has the expectation that I expect this to be a national asset to share with everybody. But it's organized at the institutional level, and where this institution is concerned, these are my samples, I'm only interested in my institution. You're going to have conflicts there. So you have to start thinking about it. Who are the funders? Who does the asset belong to? And if there's a difference in the two, you have to then carefully think through. How do you meet the needs and the expectations of all the stakeholders? Next, who exerts operational control? Some places, the bank is supported by the government, but the government is hands-off. I give you money, you do whatever you like. In many places, it's not like that. Generally speaking, whoever gives the money wants to have some control and operational control, and this also plays a part in how you formulate your biobank and the policies of your biobank. What is the relationship between the biobank and the various stakeholders, the pathologists, the surgeons, the scientists, and the funding agency? So these are things that we have to consider. So first of all, structure of biobank. There are, in Singapore, we have central collection and central storage. For example, my hospital in the National University Hospital, the Tan Tock Seng Hospital, which is the second largest hospital in Singapore, they have a central storage and central collection. Instead of having multiple biobanks, there's only one for the whole institute, and everybody must bank with this central biobank. Now, there are still funny surgeons who like to keep a bit of samples in their own fridge. Those are not the ones you're talking about. They will be caught out later. I know about horror stories because one year during JCI accreditation, some of your hospitals are JCI accredited, the auditors went into the pantry of the department, I think it's the surgical department, and opened the fridge of the pantry. And not just you have drinks and cakes, you also have blood and tissues. All kinds of funny things will happen like that. So obviously, it's not because the department has vampires among them, but you have got these other kind of practices which are not regulated, which obviously we don't want. So if you allow, the institution has to decide what kind of biobank do you want, what kind of reputation you want. Do you want to basically put your foot down and say, too bad, everybody must bank with a central biobank with good controls, or are you going to allow them to have little satellites? Now, SingHealth, the other hospital, which is the largest hospital in Singapore, the Singapore General Hospital where I used to work, they have a central storage but with satellite collection sites. So they have multiple institutions, many different hospitals located far and wide. So you have got little collection sites, each one with a small fridge to collect samples temporarily, and then they transfer them to the main site where you have central processing documentation. So there's governance, central governance by the biobank, but with multiple collection sites. Now that's a model that might work as well, provided that whoever is exercising control at the central lab really has teeth to control, and you don't have the separate institution says you don't mess around with me, I do whatever I like to do. You must have control. Third, you can have a virtual biobank, a little bit like KNRC model, where what it is just it's a database. And you have multiple biobanks, each of them are all completely autonomous, have their funding from the government or the institution as the case might be, and what you do is just a database to link everybody together so that the researcher, by going through this central database, will know that hospital A has this sample, hospital B has that samples. That will also work. So you have to think through about this. Now obviously, when you move to the virtual biobank has very little operational control over what happens on the sites, which means to say that you have to be very careful about who you want to adopt into your network, because they may be of different standards, and we talk a lot about standards this morning. So that's something to think about. Central collection, central storage, best control. Everybody follows the same code of practice is the best control. But the disadvantage is that if the institutions are located at different locations, different sites, it may be difficult to exercise that control effectively. So those are the considerations. Engaging the stakeholders is a very important component. And we need, as I mentioned here, that we have the various stakeholders. We have the patients, surgeons, pathologists, researchers, funding agency. The main stakeholders in human tissue biobanking, these are the ones, and you cannot ignore any one of them. It is true that many times in the past, biobanks forget about the pathologists, forget about the patients, forget about certain groups of people. You can no longer do that if your biobank is going to be successful. So I'm going to go through each one of these. So first, the patients. What are the concerns of the patients? What are their interests? The patient is concerned, will I become a guinea pig if I donate tissue to you? The answer is no. So you have to make it very clear. This is different from a clinical trial where I administer drugs to you. This is a situation where the tumor needs to come out anyway, and therefore we're only taking from it. So that's the second concern. Will you take more tissue from me than necessary? I have to come for operation, so I know that I come to a hospital for operation to remove my cancer. You will take blood from me. But you only need to take 5 mils of blood, but instead you take 10 mils because you want to give 5 for researchers. Is that a concern? So you have to address that, make it very clear to the patient that in terms of the tissue, we are not taking more tissue. It's not just buy one get one free. Take out your liver, take out kidney as well. So you have to make it very clear that we're only taking out whatever has to be taken out for your surgery, for your treatment. So the tissue is never an issue. Patients tend to have more issue with blood, because blood will be additional than what is needed for your treatment. And you must be honest. You have to tell the patient that actually we are going to take additional blood for the purpose of research, because the tissue without blood is not so useful. But we are not going to take that much. How much? 2 tablespoons. That's about 10 mils, whatever. You have to tell them. Of course, they'll ask how big is a tablespoon. Not a whole huge ladle. So you have to give them some idea of how much it involves. And I must say that no patients that ever said no to the donation of tissues, but about 20% of the patients will refuse the donation of blood, because their idea is maybe cultural. They say that the cancer has to come out anyway, but I'm so weak already after operation, there's loss of blood in the operation, and you want to take more blood from me. So they are not willing to. So that's a problem. How do you overcome the problem? Sometimes, you're not willing to donate blood, we cannot force. Is it okay if I take a swab, a barcode swab? At least I get some DNA, you see? So that one usually they say, yeah, that's not a problem. So you can take a barcode swab, the next best thing. Will it affect my treatment if I say no? And that's the biggest concern. And this is especially if the person taking the consent is the surgeon. So it is not ethical for the surgeon who doing the operation be the same person to ask the patient for consent to donate tissue, because the patient might feel that I'm obliged to say no. If I say no, the surgeon might not do a good job. So that is indeed a concern, and in Singapore it has to be a different team. It should not be the same person, because there is a risk of this undue pressure. And in law, if you have made a contract with undue influence, that contract is voidable, it's not valid. So anyway, you have to be careful about this. It may make very clear that whether you say yes or no, your treatment will be exactly the same. What does it mean to participate? Do I have to keep coming back to the hospital? This, of course, is not necessary. Then you have to explain. Will you be contacting me every now and then to ask for more history? If you are, then you have to explain to the patient, yes, we will contact you again later for further interviews. Or will you not be contacting me ever again? So these are the things that you have to consider. What about my privacy? How do you protect my clinical data, the dates, to make sure that people do not leak it? We had very bad instances of leakage of data. So you may have, following the newspapers, you might realize that Singapore was hacked by, there's an international group of very professional hackers hacked into the hospital system and managed to get the data, the medical data of our Prime Minister. And they were interested in the medical data of the Prime Minister. I don't know why. But there are things like that. So you have to make sure that your system is in place to protect the data. And recently we have another big problem, just came out in the papers, about someone who works in our Ministry of Health who have access to HIV patient data. He needs to access it for part of his job. And he has a boyfriend. He himself is gay. And his boyfriend accessed his data, and because the boyfriend was committed a crime in Singapore and he was angry at the government, he leaked out the data. That is dangerous. So all these things can happen. So we have, when we are as biobankers, we are custodian of all this information. What systems we have in place to make sure that this data is not leaked out? So we have to convince our patients that our systems is robust enough so that it will not be leaked out. So that's something important. Will my insurance rates go up if you find something? And this is particularly important if you're going to return incidental findings. Because you take the patient samples and you do genetic whole genome sequencing, you find a BRCA1 mutation, and if you tell the patient that you got BRCA1 mutation, what does that mean? He has to declare, and the insurance rate may go out. So all these are things that you consider. Will you be contacting each time you want to use my samples for research? Most patients don't want you to contact me each time. So, but then you need to give, then you have to consider what kind of consent you're going to give. Because if your consent is only for one project, you can't use the sample for next project. You need to keep reconsenting. So these are things that you consider about that. Will I know the results of your research on my samples? Do you going to return results on samples or not? We'll talk about that later. They are good and bad. If you return the results, there are also a problem for the patients. Some patients don't want to know. A lot of our patients in the early days when HIV first came out, I tell you, it was terrible. Those days we don't know how to treat HIV patients. It was a death sentence. I was working in a hospital where we saw most of the HIV patients. And every now and then we have people committing suicide, jumping off the buildings. And because they knew that they're HIV positive. Are you sure you want to return all the results to the patients? So does patient wants to know? Patient has a right not to want to know. It's not always a good thing to want to know that you've got a condition that you can do nothing about. Do you want to know you got BRCA1 mutation? What are you going to do about it? So there are sometimes maybe things you can do, some things you cannot do. Now I have a genetic condition, thalassemia minor. Now those of you who know thalassemias, it means to say that if two thalassemia minors get married, you may have a child with a thalassemia major, a serious condition. It means to say that every girl you meet, you say, can I have 10 mils of blood? Let me test it first. There are implications here. So not everybody wants to know. My sister says, no, I don't want to know. I told her, I'm telling minor, do you want to test before you get married? No, I don't want to know. Ignorance is bliss. What do you expect me to do? So patients has a right not to want to know as well. So all these considerations, you have to explain to the patients, and we have these consent forms, we explain all this. Our consent process is a process. It's not one time. It's not, do you agree to donate your tissues to research, yes or no? That's not good enough. You have to explain what are the implications, what will the samples be used. Will you be allowing samples to be used for all kinds of research? Some people may have certain considerations. For example, at one time my research was funded by a Buddhist society. And the Buddhist society says, we will fund your research provided no animals are used in your research. So similarly, patients may also want to donate tissues for research as long as no animals are involved. So there are maybe conditions attached to it, and you need to track them. and all these have to be explained to them, and sometimes patients need time and you must give them time. So our regular process of taking consent is that first we need to train our consent nurses. How do we train them? Or lectures, demonstration. We also have role play. So therefore we hide behind a two-way mirror and then we let them someone pretend to be a patient, and then you have to see how they explain to the patients and then give feedback. This is what you should have done, this is not good, and so on and so forth. Very often we also explain to the patients that you need to take some, you may have to explain to the parents, your husband may want to know about it. You take this brochure back home to think about it, and then we can come back again. We will ask you again tomorrow. So you need time. In Singapore, we have many different races. So all consent form must be in 4 languages: English, Chinese, Malay, and Tamil. So these are the 4 official languages. So everything has to be translated. And then the witness, the person who gives the consent, must be able to speak the language. It's terrible if you say that, oh, you have taken consent from the patient, and the patient says, but I don't speak English. How can I be giving valid consent? Obviously, you will not do very well in court. So you need to have an interpreter. You sign to say, yes, I've interpreted it, and the consent form must be in the form that they can understand. We mentioned about that, about publicity as well. And one of the things we do is that when we have research breakthroughs, especially in the papers and so on and so forth, we explain to the patient how your tissue can help research, how it can be useful so that patients also want to know, I donate the tissue, will it be useful or not for research? Does it achieve its purpose? Next, surgeons. And this is a very important group and very difficult group of people to deal with. Surgeons, especially in Singapore, very powerful because they bring a lot of money, and I think many Asian countries it's the same. They are very powerful because they bring a lot of money. A lot of times surgeons, being who they are, very highly stressed, they make decisions very quickly. So surgeons tend to be people who take this position that's, they're almost like gods in the hospital sometimes, So I operate on a patient, the patient is my patient, the tissues is my tissue, it's legally not their tissue. They have been challenged in court before in the West, and the court has made it clear it's not your tissue, but they think of it, that way. Now first, they say, what's in it for me? I give you the tissue for tissue bank, you get your publication, get fame, I get ignored. I might as well dump everything into formalin. That's not so good. Actually, one surgeon told me, I'd rather dump it into rubbish than give to you. Why should I give it to you? How will you benefit me? If I allow you into my operating theatre to harvest samples from my patients, then I should be able to access my samples free of charge because they're all mine. I don't want to give you away my samples to all my because you can give my samples to my competitor, the next surgeon there. Then he does his publication, and because I'm so busy doing operations, I give you so much tissue, in the end he gets all the honor. Why should I help you? If you collect clinical data from the hospital records, how can I be sure that you will not publish it without informing me? If you get my tissue and then you can get our clinical data, maybe you publish it without informing me. So I don't want to give you my tissue. Then I have control. What if the scientists play me out and leave me out of the author list? They say, yes, I will include you, and then when they publish, they leave me out. Then what happens? So the biobanker must answer each of these questions. You have to think about how do you address this in your policies, and then how do you deal with it. So how do we deal with it in my institution? Okay, in our biobank, we have this policy. Again, everyone, you have to decide what is good for you. This is not necessarily works for you, but it works for us. The surgeons will contribute tissue and is banked centrally. But the surgeon contributor will always be contacted before any tissue release for a project. We will invite the contributor to be a collaborator in the study. So every researcher, you want to access tissue that's contributed by this surgeon, you can only access it if you include that surgeon contributor as the collaborator. Now then you say, oh, but then he has got no scientific inputs. Why should I include him as an author, as a contributor? So therefore, we create a role for the scientist. We will not, in SingHealth, we do not give you the clinical data, and we do not store the clinical data. That was the first model, remember, under clinical data. When you need clinical data, we will ask the clinician contributor to get you the clinical data. So their role in the research is providing the clinical data. So therefore, there's a legitimate scientific reason for them to be in the publication, and they also feel that their interests are protected. And because of this, we tell the surgeon, you contribute, if you keep it yourself, then you can only give your tissue to a small number of researchers or some small number of projects. You contribute to the tissue bank, then a lot of researchers will come to us and more people will make use of our tissue, which means you will be collaborators in more projects. That means you got more publications. So it's in your advantage to contribute to a tissue bank rather than keep in your own home, in your own lab. So that is the argument they give. And publication from researchers, what happens is the scientists play me out. They say yes, later don't include me. Don't worry, the biobank has a role. We screen all the publications. Every time we give tissue to a researcher, the researcher must update us and we will chase them. What publications has arisen from the use of those tissue? We look through the publication, we search and make sure that the contributors' name are there in the publication list. If they are not there, we blacklist that the person, they will never receive samples from us. So this is the way to ensure our collaborating clinician that we also protect their interests. Okay, so this is what we do. So here we have in our request for tissue form, request for materials, we have the principal information, but we also have project collaborators. And the project collaborator must include the name of the surgeon. So therefore the surgeons are always part of the collaboration and we screen them. Because everybody comes to us and asks for tissue, we look through the project collaborator and we look and see whether the name of the contributing surgeons are there. The name is not there, we will not give them any samples. So this is a way by which we protect the interests of the surgeon. Next, the pathologists. What are the pathologists concerned about? Number one, will the tissue harvesting compromise pathological assessment? And that's very valid because the pathologist takes the legal responsibility for the report. But the sample that I have before me actually has one piece of tissue missing. How can I be sure that my report is accurate? That is a concern. Second, I don't have time to harvest tissues for you. I'm very busy as it is. Very true. And no hospital, certainly not in Singapore, no CEO will allow a pathology department to have more pathologists than you need. They will look at a workload and say your workload requires 10 pathologists, I will give you 9. The rest of you can work harder. They will never give you more. So how do you deal with this? Third, if I cannot make a diagnosis after tissue has been harvested for research, then what then? Who takes a liability? So that's the concerns of the pathologists. We have to answer them. Now in Singapore, the Bioethics Advisory Committee made it a requirement that no sample can be used for research unless the diagnostic pathologist certifies that the taking of the subsample will not compromise the main diagnostic purpose. So this is required, and this is now transferred into law. The Human Biomedical Research Act, which I'll talk about later, actually puts this into law. So it's a requirement that the pathologist must be part of this harvesting process, and so we hire research pathologists, as I mentioned to you this morning. So this deals with the questions that a pathologist has. They don't have time, but they want to have a control. So we bring in research pathologists from Myanmar, from Philippines, wherever, and we train them in the pathology department. The pathologists exercise control in the training and say that yes, they are good enough. I can trust these fellas, and these are the only ones allowed to harvest tissue. The surgeon is not allowed to harvest the tissue. It has to be the pathologist that is trained under the supervision of a pathology department. And in this way, because the pathologist is already very busy, they won't be doing this. They are able to do that through the help of the pathology associates. Next, researchers. I need a large number of samples. The reviewer says my study is too small, but I cannot afford your charges. Big problem all the time. Why must I include the surgeons as authors in my paper? They are merely butchers. I tell you, these are real things that the scientists have said to me before. I need high quality tissue samples. Can I be sure that your samples are of good quality? Is the material I get from the biobank what it says it is? Big concern. There's too much paperwork, too many regulatory bodies deal with. There's IRB, Tissue Access Committee and so on. How do I get the samples I need without any fuss? All those are questions of the scientists, of the researcher. We have to address them. So we have procedures in place to explain to the surgeons, the researcher, how they need to, the process to get the samples, particularly for fresh samples. First of all is information. You must give them information so that they know what is the process that they need to go through in order to get the specimens that they need for their research. How do the researcher gain from this? Number one, to a biobank, you can access to large quantity of research material that's collected in accordance with ethical principles and following best practices. Yes, a researcher can go to your favorite surgeon, give you a sample, but not having a central biobank to ensure the quality, you get the tissue, but is the tissue what it is, what it says it is. So we need to ensure tissue assurance, quality assurance, and here we have professionally trained research pathologists harvest the samples following set protocol and ensuring that the QC is done. And we have also had to ensure that these samples can be obtained linked with clinical data so that you have not just the tissue but also all the metadata associated with it. This is an advantage for the researcher. Now, as for some of the questions such as, what do you do about costs? I cannot afford your charges and things like that. Those are not issues that the tissue bank really can answer by itself, but we basically find ways to deal with it. For example, give you an example. I want to encourage research that is productive. You can give 1,000 samples, that researcher never publish anything. You sure you want to give sample to that researcher again? So I also follow up. Every time I give samples to researcher, we want them to tell us what publications do you have, and we keep monitoring. What is the journal impact factor? I look at the cumulative journal impact factor that is produced from a single sample I give to him, and I divide it by the number of samples that he has got. So I have, for every sample, I get 0.1 journal impact factor. Okay, this is the standard for this researcher. Another researcher, for one sample, I get 1 impact factor, 10 times. Oh, that one, I should give him more. Another fella, for every sample, he gets 0.00000001. Maybe not so much in future. So I monitor, and for those researchers who are very productive, they got no money, I also give you samples. So I basically give them vouchers to reward them. Obviously, I must make a difference because I want to get publications that I want. If my purpose of setting up biobank is for publication, obviously, if your purpose of biobank is to commercial, to earn money, that's a different thing altogether. So these are little things that we can do. So that my message to a researcher, if you are a very good researcher, you get Nature and Science paper, no money also give to you. Don't even worry about it. You keep giving me nature paper and science paper, I will give you tissues. Never a problem. The pressure then is on them. You better produce. What about including surgeons, authors? My paper I explained. Without the surgeons, you don't get clinical data. And that is, your tissue is for very little value unless you've got clinical data. That's the reason why you need to include the surgeons inside it. As the rest of it, the high quality samples and so on, this is the reason why we have to charge. Because a lot of money goes into investing to make sure that you get good quality tissues. What about paperwork? I also hate paperwork. And I think the tissue bank has to look through the paperwork and see, are there things that you don't need? Do you need to always ask for the CV? When the person, when a researcher submits a grant for a grant application, they put in the CV there, they put in the research intents, the research project, all that is there. You don't need to ask for it again. You have submitted it and you got a grant application approved. Basically say, give me your grant application that you submitted. Everything is there, good enough. I don't need any more information. So you cut your paperwork to the minimum. Secondly, in terms of approval, we don't use paper, we use email. Instead of convening a meeting once a week or once a month to meet up to approve, why do you need to meet? You just go through electronically, you just route from one to another and you can clear it very fast. So you need to be able to approve everything within 2 weeks. All the considerations thinking through 2 weeks, you must approve. So we have deadline to ensure there is a timely manner for approval. Okay, so next, dealing with the next group is the funding agency. And this is a very important group. The funding agency, what are the interests of the funding agency? They want to know, can the biobank be self-sustaining? We always have this question. This is a difficult question, and my honest answer to the funding agency is that no biobank can ever be financially self-sustainable. No biobank, no academic biobank. If you started a biobank as a commercial biobank to earn money, that's totally different. But any academic biobank, there's no way you can be financially self-sustainable. So I want to ask, if you're asking me whether you can be self-sustaining or not, then I ask, why do you want the biobank in the first place? Or what's the purpose of a biobank? You have to think through. At the best, what we're talking about is co-payment. Basically, the funding agency provides 60%, 70% of funding. The remaining will try to recover from costs and from the charges and so on. But if you want to have 100% self-cost recovery, you have no research. So you seriously have to consider that. Can you find other streams of revenue? Yes. Often they always ask. So you say that you cannot be completely self-sustaining. Then can you find some other revenue so you don't have to pay so much? Why can't pharma pay for all the operations of the biobank? My answer is yes, they can. But if you only supply to pharma, and your researchers will never be able to compete. So what exactly again do you want a biobank for? You want to earn money? I can be a commercial biobank and just supply to pharma. What exactly do you want? How do you ensure data sharing so that I get bigger bang for your buck? Now, I said this is a good question and that's reasonable. I'm investing into research. I'm investing in a biobank. Do I get returns on my investment? How much ROI can I get? How can I ensure I get ROI? Answer the last question, I already explained to them. I monitor the researchers who get samples from us. And I tell them to make sure that I look at how much publications they have, the journal impact factor, and I show you from these per samples I give out, I know which are the ones who are good producers, which are the ones who are not good producers. Those who are not very productive, I will charge more. Those who are very, very productive, I don't even charge. Because I want to make sure that I achieve the purpose of the funding agency, which is to say that I want to ensure data sharing. The other bit is about data sharing, and I'll explain this again. You see, tissue bank is always not a very cost efficient. You get a piece of tissue from me, you got money, you pay for it, you do next gen sequencing. You get another piece of tissue from the same patient from me, again you do next gen sequencing. Everybody is taking the samples which are doing the same thing. Why don't you just share? But people don't like to share. So what do we do for that? Okay, one of the things we've done is that it's a requirement as part of our policy and SOP, we'll talk about policies as well, is that if you take samples from me, you must agree as part of the material transfer agreement that upon completion and publication of the work that's done on this piece of tissue, you are required to inform me what data you have collected, what data points you have collected. I don't need the data values. I do not need what is the value of the itself, but I need to know what fields you have collected. You have done next-gen sequencing. Okay, what else have you done? I've done some transcriptomic studies. I have done this, I've done that. I have done IC for P53 or whatever. I need to have those fields. You don't have to tell me whether P53 is positive or negative, but you tell me those are the fields. And I will put that in the database and it's available to all researchers. So that another researcher who wants to have the sample for the purpose of doing next-gen sequencing, I say, don't need to do it. I can link you up with the other collaborator. By collaborating, you get the data. Don't waste the sample. You can use the tissue for something else. And by doing so, what it means is that your database gets enriched. Over time, this researcher has done next-gen sequencing, another researcher has looked at microRNA, third researcher looked at mRNA. You have all these fields there. You don't need to report. The tissue then you have as you go along become more and more valuable. When I give a tissue to you for a new kind of work that you're doing because you want to generate some xenograph or cell line, this xenograph or cell line has the data of next-gen sequencing, has a transcriptomics, has all the IC data that other people have done. By collaborating with the other researchers, you have all that in your xenograph. You see the value of your xenograph, your tissue becomes more and more valuable over time. So this is to answer the funding agencies. I make sure that your investment becomes even more valuable over time. So these are things that we can do. Now this is something I mentioned previously also. If we look at it, in 2011 example, we have about 1,000 colorectal samples collected. This is the total amount. But then I look at 2011. What is the type and number of samples withdrawn? Where's colorectal cancer? There. You collect so much, but the amount used is so little. And therefore, basically, as I mentioned to you this morning, we don't collect any more colorectal cancer if the amount of colorectal cancer I have in the bank is 3 times more than the total amounts being issued in the last 5 years. So if things change, I will collect more. But if do not change, I will not collect more colorectal. This is to make sure that your samples are always fit for purpose. A biobank needs tweaking all the time. You don't start a collection and then forget about it, runs on its own. It doesn't. So you need to decide, now at this point in time I collect more of this, at this point in time I collect more of that, at this point in time I collect more types of samples, another time I collect less types of samples. So data sharing policy, I mentioned that in passing just now. Researchers will deposit a copy of the publications with the repository. The published abstracts will be available online. And upon completion of the project, they will list all the data fields, not the data in the study, and therefore more people can make use of the data by sharing. And they will not waste the tissue by doing next-gen sequencing on 5 samples of the same tumor. That's what we don't like to do, and this is something that we have on the website. You can see the list of collections and who they are, what they have, and the abstracts they've done. The idea is that from the abstracts, you know what kind of work they have done before, and therefore you don't have to repeat. You can just collaborate with them from the data as well. Now I'm going to share with you a mistake that we have in Singapore. This number of years ago, and this is to show you, to illustrate to you the importance of considering the needs of the stakeholders. Now, the Singapore government gave something like, spent about $10 to $12 million around the year 2010 or so. This is a time where everybody is very hot about tissue banking, that's very sexy, to develop a national biobank. But a couple of years later, the biobank closed. It didn't work. And biobanking is an expensive long-term investment. It appears that the main problem was that the cost recovery charges is too high, discouraged the use of samples, and basically the usage was not very high, and it's no longer sustainable. When it's not, and one big problem is that this tissue bank did not have clinical information. So most of the clinician scientists interviewed, they would rather get the samples directly from the hospital than use the national tissue bank. Let me explain how was it structured, and what was the mistake? Why didn't it work? You see, in those days, Singapore government, our government is quite shall we say, it's very central government, kind of very strong government. So they want to regulate, control everything. So the government says that right now, all the tissue bankers, we are held at ransom. This surgeon don't want to donate, to contribute, another researcher cannot use the tissue. So I cannot allow this. So I want to control it from the top. Now, Singapore government, very powerful. So, okay. Shut up all of you. Every surgeon must contribute tissue to the national biobank. I'm starting out the biobank. Everyone must. No question of whether you willing, not willing. Everybody must donate tissue to the biobank. I will fund it. I will give money. But then they say, hey, not fair. You don't, there's nothing in it for us. Okay. From the samples you collect, one half will keep in the national tissue biobank. The other half you can keep yourself for your own research and things like that. But the collection funded by me. Sounds good, huh? The difference is the samples in the national tissue biobank, I can give to whoever I want. You have no control. You cannot say no. I can decide to give. That's the whole reason behind why the government has this, to overcome the objection of the self-interest of the hospitals and the surgeons. But the government at that time, they didn't consult me, they just did it. But they have a pathologist consulting them. The thinking was a bit shallow. So they collected the tissue, they collected the blood. They thought that's all you need because they were advised by scientists. But these scientists were doing basic science. They were not doing translational research. They don't realize, without clinical data, your tissue is of very little value. So they never collected clinical data. The hospital keep the clinical data, they didn't contribute because they say that I'll need to give tissue, right? So I don't need to give you. Then, and on top of that, when you give the tissue, I got one piece of tissue only, not very big. What do? Tumor, I keep in my own biobank. You need the other half, right? I cut a bit of fat, I give to you. Necrosis, I give to you. The tumor, I keep. You pay for it, I benefit. It didn't work. It's not sustainable. Will anybody go to the National Tissue Biobank to use tissue? They won't. They'll use the hospital one. On top of that, the hospital has clinical data. So the problem is that they did not engage all the stakeholders. They thought about it, and they said that these are very troublesome people. Everything they ask, what is in it for me? I don't want to do that. I just use the power of the government, says all of you must contribute. It doesn't work. So therefore the message from this is that we have to seriously think and have to engage all the stakeholders. People are very smart. You have a law, people have a ways to find a loophole immediately. So we have to think of a way to engage everybody so that everybody feel I gain by working with the biobank. So that's something we have to do. So why did it fail? Failure to get buy-in from stakeholders. Surgeons are not engaged as collaborators. They never have agreed to it. They are not collaborators in the studies. The pathologists are excluded, so therefore you don't get pathology data, you don't get QC. Nobody QC the samples. The hospital sample, they QC. The one that's gone to National Biobank, no QC. All those are issues. Physicians are excluded, so therefore no treatment, no survival data. Your tissue is of very little value. As I said, the government was not very smart. They thought they were smart, but they were not. They funded. They said, I give you funding for it, but they funded the second sample, which is the valuable one used by the hospital. Nobody is using a sample that got, and because it's top down, there was never any buy-in by the healthcare institutions. Okay, so something to keep in mind when you're trying to do this, especially if you're trying to regulate and rather legislate, using legislation to force everybody to do it, doesn't always work. Next, I want to talk about consents a little bit more, and this is the biggest issue. The great thing I like, as I always said, that human tissue banking is so much harder than microbes. The main advantage about the biggest problem for humans is that we need to take consent. Microbes don't need to take consent. You can do anything you like. But humans is a problem. And the consent issue is very complicated. And first of all, let's consider consent. Why do we need consent? In medical treatment, consent is a defense against a charge of battery. Meaning to say that if I go, you think about what we doctors do. Sometimes you don't think about it. Patient come into the thing, I take out my stethoscope, the woman start undressing herself. It never happened anywhere in the world. It happens because in the doctor-patient relationship, if you come to see me as a medical doctor and I take out my stethoscope, you have implied consent that you want to listen to my heart, and so you start unbuttoning the dress because you know that it's informed, that is deemed consent. And if you don't have the consent of the patient, and you start undressing the patient, you start cutting the patient, poking a needle to the patient, all these are actually illegal acts. These are battery under the law. You can go to prison for it. So battery, all these things that we do as doctors day in, day out, they are not illegal purely because patient agree to do it. So it is consent. So consent is a necessary defense against a charge of battery. But in clinical trials, different. Clinical trials, the same considerations may apply if you're giving drugs to the patient, but there's additional bits here, and that is to say that while I examine the patient, I treat the patient benefit. In clinical trials, the patient may not benefit. It's the other patients that might benefit. That's something that they have to consider. But in research, in human tissue biobanking, consent has already been taken for surgery. Remember, the patient already agreed for the tumor to be taken out. The consent that we are talking about now is the consent to use the tissue that has already been taken out. So why is it needed? Is it needed as a defense against battery? No. Because that consent for surgery has already been given. So what is the purpose of consent in tissue biobanking? Is it because of ownership? Oh, the tissue belongs to the patient and therefore I need your consent, otherwise I cannot use the tissue. Guess what? The tissue doesn't belong to you. At least in common law. I'm talking about British Commonwealth, not sure about Thai law and the rest, but under British Commonwealth, this arm is mine because it's attached to my body. You cut it off, it's no longer mine. It's no longer mine. I no longer own it. So there is the common law principle that there is no property in a human body or parts thereof. So, give you an example, so this is the one for Moore versus the Regents of University of California, famous case where what happened was that John Moore was a technician in the pathology department of the Royal College of Surgeons, so they have a lot of specimen pots there. But he was also an artist. So he stole the specimen pots of the head, of the arm and so on, removed the specimen from formalin, and then he made a cast of it and make it as an art form, which he exhibited. So the Royal College of Surgeons, when they found out, they sued him for theft under the Theft Act in the UK. But guess what was his defense? His lawyer's defense is that my client is not guilty of theft because to steal something, there must be property, rights. So if there must be a property, then you can steal. But the human tissue, that piece of tissue, body or parts thereof, cannot have, it's no property in the human body or parts thereof. Therefore, it's not property. If it's not property, my client couldn't have stolen it even if he took it, because it's not property, and therefore he is not guilty of theft. So that was the important point. So in common law, there is no property in human tissues. That's the point. The purpose of consent in biobanking is not because the patient owns it. It's not because of ownership issue, because ownership means you have property. By the way, if you're interested, what happened to him? He was convicted of theft, not because he stole a human part or human body, but the court ruled that if it's an arm you cut off, yeah, there's no property. But this is not just ordinary arm or ordinary human head. That head has been processed. It has been processed in formalin. Once it's processed, the nature has been altered from human tissue to become a formalinized human tissue, which is no longer human tissue. Once it's been altered permanently and irrevocably, it acquires property rights. And whose property does it go to? It belongs to the person who has altered it. So the hospital who has put it into formalin has altered it, it belongs to the hospital. So you are guilty of theft, of that. But if you just steal a dead body, it is not theft. So in the 18th century, we have got body snatchers, the people who, poor people who dig up dead bodies in a cemetery and then sell the body to the medical school for dissection. Some of them were convicted of theft. But how were they convicted of theft? Not of the theft of the body. They were convicted of the theft of the shroud that covers the body. The piece of cloth that covers the body, that's property. But the dead body has no property. So that's interesting about common law. So you need to know what is so the purpose, bottom line here, is that it's not for ownership. Then why do we need to take consent for human tissue? The reasons is this. It is purely ethical reasons. So consent for medical treatment, particular trial, is legal. You need to do it. If not, you are guilty of battery. But in human tissue biobanking, at least in Commonwealth, in the common law jurisdiction, unless there's relevant legislation, that means to say unless the government has issued laws about it, if in the absence of any legislation, then it's common law. And where common law is concerned, it is an ethical issue. There is no common law requirement for consent for tissue banking. But there is an ethical reason why you need to do this. So the story about Moore versus Regents of University of California, in that ruling, we went to the Supreme Court. The Supreme Court decision was that whilst the patient has no rights to demand whether or not the sample belongs to the patient or not, however, the patient has every right to dispose of the tissue that becomes from him in a way that he sees fit. Meaning to say this, if you go to, and this has got to another case, sorry, this is a case of a patient who had hairy cell leukemia. So this is a patient with hairy cell leukemia. They took out the spleen, and from the spleen they developed a cell line, which became very valuable, and they started selling the cell line. So the patient then sued the hospital for selling and benefiting from that cell line. And so the court has to decide whether the patient has rights to royalties from that spleen or not. Now, to have royalties, he must be argued that the spleen is owned by the patient after it's removed. The court, of course, using common law, says no, the patient doesn't own that the spleen. However, the patient should have every right to give the spleen to some other people, some other pharma, instead of giving it to the hospital to develop into a cell line. But the patient was not consulted. So in this, the hospital did wrong by not consulting the patient whether he prefers to have that spleen developed into cell line by somebody else, even though he will never get royalty. So that is an ethical issue, that you have taken away the autonomy of the patient to decide what to do with the samples. So tissue banking is for a respect for autonomy. The patient has a right to decide what to do with the tissue, not because the patient owns it, but it is a matter of ethics that you should consult the patient. So in the Moore case, Justice Moore said that just as Moore has the right to do his own tissue, what the defendants did with it, as I mentioned, that the patient, the hospital did not give the patient the chance to decide how to use the sample, how to dispose of it, how to commercialize it, even if he wants to. So then, next thing about consent. So now that we established why do we need consent, it's mainly an ethical reason until you have law. Until now, Singapore had no law about consent in the use of tissue for research. Now we do, because the Human Biomedical Research Act has been enacted. And in that act, the law dictates that if you want to engage in any research involving human tissue, you must take consent. In fact, as I'll explain later, the act is more detailed. It also says what must be present in that consent form. Okay, so then, consent in biobanking can be conditional, meaning to say that I give consent for the tissue to be used in this kind of research and not for other research. It can exclude other kind of research, only in research that does not involve animals, or only for research that is done in Singapore, in your own country. Can the research be used overseas? So the patients can impose conditions on their research, or the patient can basically say that I allow this to be used in all ethics approved research, which is my favorite. So normally we advise the patient, would you allow the research to be used for all ethics approved research, because they can benefit even more people. 100% of our patients will say yes. Once you put it to them in this way, unless there's some religious or some racial or societal considerations, because it is out of altruism that I donate the tissue. I want it to benefit as many people as possible. So usually that's not a problem, but you must explain to them. Secondly, can your consent be withdrawn? Now, of course, you're giving drug to a patient and the patient doesn't like the drug, the side effects, the patient has every right to say, no, I don't want, and it can be withdrawn. But what about tissue? The tumor is taken out already. If the patient no longer says, I want you to use it for research, you cannot put it back to the patient anyway. So you just means you cannot use it any further. Will the consent be withdrawn or not? Now this question, with regard to consent for tissues donated for research, can that be withdrawn? Can be dealt with in two different models, two different ways. What do I mean by that? First model is what we call a tissue donation model. Now, tissue donation model means to say that I am not giving you permission to use my research, to use my tissue for research. Usually that's the usual model. Do you allow your tissue to be used for research? A permission. If it's permission, then the permission can always be withdrawn. But we are using a different legal model. I'm asking you to make a gift, not to give a donation. If you make a donation, what is a donation? A donation or a gift is an irrevocable transfer of property from one body to another without charge. That is irrevocable. So, example, if I ask Dr. Lily, can I use your house for a party this Saturday? She can say yes or no. It's a permission, right? After the party is over, the house is hers. She can also say no after she said yes to me. But if I say, Dr. Lily, you like me so much, can you give me your house? And she said, yes, I give you my house. After that, she cannot say no. I want it back. It's an irrevocable gift. I can have parties every Saturday as long as I want to, because it's now transferred to me. So we are using tissues in this way. The first model is a common model. I ask for permission to use your samples for research. Second model that we have used is to ask the patient to make a gift of your samples for research. But that means explain to the patient very clearly, by making a gift, you revoke all rights to the sample thereafter. You have no rights in terms of whether I use it for commercialization. You have no rights about taking the sample back. Absolutely no rights. You have no rights to demand that you want to know what results, what research has been done on the sample. Nothing at all. Of course, that's very clean from the legal perspective. And so we have used this model as a donation model. And this was actually recommended by our bioethics advisory committee long time ago, actually. And the reason was because it was checked by a judge. So the legal person will, of course, prefer that because it's clean. This, of course, implies recognition of property rights, by processing the sample that becomes property of the biobank. That's not so much of an issue. The bigger issue here is that our ethicists don't like this model. Our ethicist says that by asking the patient to give up all rights with respect to it is not very ethical, because people have the right to change your mind. You can change your mind. I give you my house, I may regret it later on. But to say that, but it's a house, it's just, it's inanimate. But this is tissue, it's very sensitive, it's part of my body. I should have the right to change my mind. So the ethicists don't like that so much. Unfortunately, this gifting model, this transfer model is no longer allowed in Singapore because the Human Biomedical Research Act now does not allow that model. It is using the permission model. But this model in some countries might still work, and we used this model before in the past, and this is very clean and it's very easy to operate. So consent. What else about consent? Informed consent is essential. Consent is not just basically saying, oh, uncle, you're going for operation, right? Can you also help research by signing this? And the patient is not very clear sign. Is that consent? That is not consent. The patient has not been given enough information. So consent has to be informed. If you do not know, if the patient does not understand the terms of that donation or that permission of the tissue donation or the research, then it is not valid consent. So it must be valid consent, so you need to provide information. In general, pre-op consent is the rule. Normally, we take consent before we take the operation to take the samples out. But we allow post-op consent where valid pre-op consent is not possible, because it is true that sometimes the patient is very ill. If the patient is very ill, it's not in the position to provide consent before the operation. And even if you take consent, it's not valid because the patient is not in the state of mind to give valid consent. We can take consent after that. Particularly in children cases. Parents with children going for major surgery to remove a brain tumor, they are very stressed. That is not the time to ask them to donate tissues. They are more concerned about the patient's well-being. But you can take consent after the tumor has been removed because the tumor has to come out anyway. I explained that earlier on. Post-op consent, we allow that for removal of the tissue, but you need pre-op consent for blood because you want to take extra that's not required for surgery. And if you want to take it for fresh cells, you need pre-op consent. But for frozen samples, we allow post-op consent. Consent from parents in the case of minors, obviously. Now here again it's very interesting. I do not know what's the case in your country. Do you take consent from the parents alone, or do you take consent from the parents and the child? So the ethical standards may vary. In the past, we only take consent from parents. Now, as I'll explain later on, the law requires us to take consent not just only from parents, but also from the child, if the child is able to understand it. Consent to access clinical data, clinical records, because you may have consent for the tissue, but you forget to put inside consent form access to clinical data, then you can't use the clinical data. So you must make sure you have consent for both the tissue and the data. So this is an example of consent form. You can no different to the rest, but basically just to mention that we also mentioned the access to the clinical data that is if required. Now, issue of consent. As I said, we use consent as an outright gift, and it's a different concept from consenting to participate in the clinical trial. So our consent is a donation model that was used previously. Now, as I said, this is no longer allowed under the new law. And for a donation, I love this tissue donation concept because from the legal perspective, it's very clean, it's very easy. Here, the donated tissue is made very clear. It's an outright donation, and the patient is very clear. You will not be able to withdraw the donated sample once it's stored at a repository. Made it very clear. If you don't agree with these terms, don't donate. We still get practically 100% donation. Patients don't really care where that's concerned. So if your law allows it, this is a very clean model. What about minors? And I'm going to talk about this as well. I'm not sure what is the law or the thinking in your country. In the past, children are not considered the same as adults, so they don't get much rights. And usually the parents say, okay, it's all right. Now, in the West especially, the understanding is changing, that children also have rights. And if the children is able to understand, the children should be treated almost as an adult. Now, the age of majority in Singapore is 21, much older. The age is majority is 21. I'm not sure what's the age of majority in Thailand. 18? 20? Also 21. Well, 21 is the age of majority in Singapore, not 18, because part of the reason is Singapore has national service. At the age of 18, all boys have to serve the nation as soldiers. If the age of majority 18, all the boys will say, I don't want compulsory national service, otherwise I won't vote for you. So age of majority must be 21. So we have age of majority at 21. However, NS boys, national service boys, therefore soldiers are not considered, they are still considered minors because they have not reached the age of 21. But we have the idea of Gillick competence. Now, Gillick is a famous British case. What happened there is that this is a teenager, a girl in the UK, a teenager wants to get oral contraceptive pills from the clinic, and the girl says, I don't want my parents to know. by one oral contraceptive pills. Obviously, she is sexually active. Now, the clinic gave her the pills and did not inform the mother. When the mother found out, the mother sued, saying that her consent is not valid because she's a minor. And therefore, you should have taken my consent, that her consent is not valid. So the court had to decide, is the consent of a minor valid or not? The decision of the court, which is now part of common law, is what is now known as Gillick competence. What it means is that if a minor is able to understand the procedure, the implications of procedure, side effects associated procedure, then the consent from that minor is valid. So that's what we talk Gillick competence. It's competent to give consent if the patient is able to understand. Singapore recognizes Gillick competence for treatment. So in Singapore, NS boys with appendicitis, they are 18 years old, they're soldiers, they go to hospital. Can they give consent for operation? We don't need to ask the parents. The child can give consent for operation. Singapore had an abortion law. Singapore was one of the earlier countries to allow a termination of pregnancy. Whose consent is required? Only the woman. Even if it's a child, a teenager, only the consent of the child. We don't need the consent of the mother or the parents. So Singapore recognized Gillick competence. As long as the child understands the procedure, only the competence of the child is required. And third, common law again. Contracts entered into by minors are voidable. What that means is that if I sign a contract and I'm below the age of majority, and this contract is contested in court, the court can rule that the contract entered in by a minor may not be valid because they have not reached the age of majority. So this is for business contracts. Now here we're talking about consent form not for treatment, consent for the purpose of research, contributing research. So one argument is that consent for research can be voidable if it's signed by a minor because this is not for treatment. Treatment, yes, we can recognize Gillick competence, but this is not for treatment. This is actually like a contract to donate tissue, a gift. That's a contract. So contract, if it's entered in by minors, is not valid. So we need the parents to agree for that contract to be valid. So that is the case for contracts entered by minors. And parents must donate on behalf of children. Now this bit, however, has now changed because I said we now have a law that covers everything about consent, including children, whether they can consent or not, and I'll explain that a little bit more later. But this is the implication if you use a donation model. The children cannot enter into that contract. The next problem comes from ethics. Our ethicists say that children should be respected more. You people are not respecting children. The parents may give consent, but then if the child reaches the age of majority, age of 21, you should ask the child whether the child agrees for that sample to be used for research, because the agreement was made by the parents, not by the child himself. So the Bioethics Advisory Committee of Singapore proposed that once the child reaches the age of 21, his or her consent should be obtained. So now that's a different thing now. The child can say no, and then you have to stop using. You can imagine that if you follow this, you need to track every child. Every sample reaches the age of 21, better remember to contact the child and whether the child gives consent or not. So that's an issue. Singapore law has dealt with this already, but if you haven't got that, these are things that you have to think through. What about clinical data? How can you use clinical data? What we do is that we explain to the patient and ask the patient to give consent for the use of, to access the patient's medical records for the purpose of research, and that must be made very clear. So I covered that already. Next, materials transfer agreements. When you give samples to the researcher, you need to have a MTA, material transfer agreement, or RCA, some sort of document that specifies the duties of the researcher, the duties of the biobank. Why do I say that? Because if your tissue has been donated with certain conditions, like I will not allow these samples to be used in any work that involves animals, then your MTA must specify very clearly you are not allowed to use these samples in any kind of tissue research involving animals. What happens when a research is over? the MTA may say that the samples, any remaining samples cannot be used for another project. They have to be either destroyed or returned to the tissue repository as the case might be. So you have to explain all that in the MTA. Those are the duties of the researcher. Now, if you have offered to return incidental finding, if you told the patient asks, "Will I know the results of the research done on the tissue?" and you say yes, then you must put in the MTA that you must return the results. If you don't put that in the MTA, the researcher will not do it and is no longer legally binding. So all those things you must think through. What are the obligations of the researcher you must put into the MTA? What are the obligations of the tissue bank to the tissue donor? And I may need to transfer some of those obligations to the researcher because I may not know that tissue has been used for another research. So all those have to be written in your MTA. So in our MTA, the samples can only be used for the purpose as approved by IRB. In other words, we don't allow our samples to be used for a second project or third project. Unused samples cannot be used. They have to be returned or destroyed as the case may be. Can you allow samples to be sent overseas? That depends. That's whether a patient allows the samples to be sent overseas. If your patient in the consent form says, "I don't want my samples to be sent overseas," then you cannot. If the patient says yes, then you can. But if the samples are sent overseas, then you have less control. And local laws may require you to abide by certain requirements. For example, under the HBRA in Singapore, we have to ensure that the samples that we taken off the patients, that we donated by patients, be used in accordance to the IRB approval, in accordance to the patient's wishes. If I take this sample and send it overseas, do I know how that sample is being used overseas? What happens if the samples is used in a way overseas that goes against the wishes of the patients or goes against the IRB approval? I must transmit all that approval, all that conditions into the MTA when I send it overseas. So all those have to be thought through to make sure that the overseas recipients agree in a contract to abide by local laws in Singapore or by the conditions imposed by the patient. So all those have to think about it. What about data? If you send patient data overseas, personal data overseas, now within Singapore, we have the Personal Data Protection Act, which makes sure that if you abuse the use of personal data, the law goes against you. But you send personal data overseas, how is the law going to cover that? There is no jurisdiction over that. Singapore law says that if you send personal data overseas, the PDPA requires whoever sending data overseas to have in place contracts with the overseas recipient to ensure that the data is managed in a way that is in keeping with a PDPA in Singapore, as if the law is operational. So the overseas recipient must agree to follow those laws. Otherwise, you cannot send personal data overseas. So these are considerations you need to have if you're going to send samples overseas. Obviously, if you say that, very easy. I know one country, a neighboring country tells me, we have no laws, no rules, so no problem. Yes, for the time being, but also may mean no tissue, because people will say you have no protection. Why should I give tissues to you? So this is something we have to consider. Privacy and confidentiality. Repository retains basic data, clinical data, and they are de-identified, but repository must maintain the links to and access to medical data. The way we do it is that the repository doesn't keep personal data. The personal data is kept in the hospital. When you need clinical data, as I mentioned, you tell us what data you need. I go to your contributor, and the contributor get the data for you. So the repository doesn't have the responsibility of holding that clinical data. That's our model. The NUH model is different. They actually collect the data. But you collect the data, you have added liability. You have to ensure the confidentiality and the safety of that data. My time is up already, isn't it? Okay. So I think with that, I will stop here, and then we can carry on subsequently in the next talk. I think we'll talk about the research data, return of research data subsequently. So I think that I hope that you have given you some overview of the legal implications so far. There's more to come, which we'll talk about after tea break.
So
thank you. Say that. What do you mean by that? You collected a specimen for a patient who, and you use this sample of prostate cancer from this man, and you use it for the purpose of research into prostate cancer. But they have performed next-gen sequencing. And they looked at the entire genome. And they found that this man has a germline mutation, BRCA1 mutation. He's got daughters. His daughters may be carriers of the BRCA1 mutation. There are implications for the daughters. Do you tell him? Do you don't tell him? If you want to tell him, the problem is, did you ask him in the first place that you're going to detect, you're going to search for these kind of genetic diseases? He may say that who gave you the permission to look for these genetic conditions? You never ask for permission. But if you don't tell him, and then his daughters develop ovarian cancer and breast cancer, and then they say, how come you didn't tell me? We could have done something about my daughter. It's a big legal issue. What do you do that? But you know, the legal issues relating to return incidental findings is far more than this. It could be something very simple. What happens if the diagnosis is wrong? For example, you get a sample from a patient and the sample says colorectal cancer. And you looked at it, there's no colorectal cancer. It's Crohn's disease. The diagnosis was wrong. What do you do? The sample was given to you for the purpose of research, but it turns out that the primary diagnosis may be wrong. Do you inform? Do you not inform? If you inform, there are medical legal implications for the hospital as well. If you don't inform, is it ethical and right for the patients? What about undiagnosed disease? You've taken a blood from the patient. They are ordinary donors. They are healthy donors. And then when you screen through them, you find that there's very high blood sugar. Do you inform the person, trace back and tell him that this person, that you may have diabetes? Is it necessary to do so? Is it a legal requirement to do so? Should it be a requirement to do so? So these are things that you have to consider with regards to your available laws and ethics. What about elevated PSA and elevated HCG? Now, these are relatively easy. Undiagnosed diseases is not so difficult ethically. You return. It's going to benefit the donor. I don't see any harm in doing so. So why not return? Yes, that one is easy. But when it's a wrong diagnosis, should you return? I would say you should. For the sake of the patient's welfare, patient must come first. Even if the hospital gets sued, patient must come first. You should return. From the ethical perspective, you return. The lawyers in the hospital will say, no, there's no legal requirement to return. Why should you return? If you do that, you're putting the hospital into legal liability, which is also true. So that's where you have now a harder decision. But the first example I mentioned is the hardest. Do you BRCA1 mutation? Do you inform the patient or not? The patient has no expectation that you find this. You never took permission to ask for this, and yet you have this incidental finding which has significant implications. Now that is a problem. There was a British case where a GP submitted some of a patient's tumor for research, and the GP was told that the patient had BRCA1 mutation. But the GP did not inform the patient because the GP thought that this was done purely for research, not for medical condition. Anyway, this woman that I examined her very carefully because I know the history. She has no breast tumors. It's from the mother. Unfortunately for the GP, the woman's daughter is also his patient. And the woman's daughter developed breast cancer later. And when she found out it was a BRCA1 positive breast cancer, the mother said, actually I sent my sample for research. And it was found out that the GP did not inform the daughter. The GP was found to be legally liable for not informing the daughter because there was a doctor-patient relationship between the GP and the daughter. The GP was in possession of information that is significant, can impact upon the patient's well-being, and he did not inform, so he was negligent. So there are lots of these issues that you have to think through about return of incidental findings. And this has become very difficult right now with whole genome sequencing. Whole genome sequencing is wonderful to us as scientists, it's terrible for the ethicists because there's so many things and all of us definitely have some mutations. Which one to return? You say clinically significant. What is clinically significant? What is not clinically significant now maybe it's clinically significant 5 years later.
And what is not clinically significant to you may be clinically significant to somebody else. A mutation that says that you are likely to be deaf by the age of 40 may not be very clinically significant to you, but for this patient who was hoping to be a musician, this is very clinically significant to him. So you need, it's very difficult to define. And also as a regulator, if I want to say return, then you're going to ask me, what should I return? Am I going to list all the mutations that I have to return? Whatever list I provide will be wrong, because there will always be something that is significant. Very hard. This is a very difficult area. So there are also some consideration. Research labs are not accredited for service. A research lab found an incidental finding, whether it's a mutation or is a high blood sugar level. Remember, the research lab may not be CAP accredited for service. The results may be wrong. If the research lab says that, oh, I found that this is HIV positive, and you go ahead and tell the patient that you are HIV positive, the patient commits suicide, jumped out the building, and then found out that, sorry, it was wrong. The test was wrong. What do you do about that? So it's very important that we must explain, even if you want to return incidental results to the patient, you must tell the patient that this result is not yet validated. You need to go to an accredited laboratory for repeat testing to confirm whether this finding is true. Do not take it that this result is true, it may not be. Clinicians and not researchers should interpret and communicate results. This is something we feel very strongly. Because everything must be taken into totality. A researcher who basically says, oh, it's a high PSA, and I tell the patient that, oh, you have a high PSA, maybe you have prostate cancer. Hey, but you may not realize that prostatitis also will raise the PSA. You need to interpret that in the context of the clinical condition. You need a clinician to interpret and advise the patient, and a researcher should not be returning incidental finding directly. So do researchers have a duty to identify and report significant findings? This is more of an ethical issue, and it's a very difficult issue. In our donation model, we ask patients to donate, make a gift. You have no rights, absolutely, we will not return incidental finding, made it very clear. On those grounds, you agree to donate, we will not return incidental finding. But that is no longer allowed. Ethicity says you should give them the permission, you should use a permission model, you should continue engaging the patient. If you engage the patient continuously, you now may have a duty to return incidental finding, and then all these questions will come in. How do you deal with it? Each institution, each biobank, you have to think through and what is the best way forward for you, what should be returned and what should not be. Remember also, patients have a right not to know. Don't force results onto the patient. I found that you are BRCA1 mutation, I must tell you. But you have a right, don't want to know. So the patient also, you must also respect the patient's right not to know. The patient needs to be asked, we have something significant that may impact your future follow-up and the risk of cancer. Do you want to know or not? But you put it in this way, the patient will say, how big is the risk? The risk is very high, I want to know. So you need to ask the patient, or the patient may say that if the risk is low, I don't want to know. Now how high or how low? You may be able to say, well, would you want to know it's more than 50% chance within your lifetime? Then I'll tell, or would you want to know if it's less than 50% chance? Something like that. You need to have this communication and then decide what to do. Is it ethical or feasible to track the donors to return research data? This is the hardest part of a tissue bank. If you make the decision that we should return incidental finding, and you promise the patient to return incidental finding, you need to track it and make sure that you return all the incidental finding. The problem for the biobank is that the biobank gives out tissues. The biobank is not the person who does the research. You do not know whether there's incidental finding that's generated unless the researcher tells you. So how can you return if you do not know there's incidental findings generated? So therefore your MTA comes in, just now I mentioned. If you want to return incidental finding, your MTA must basically say that if you find the following, you must inform so that you can communicate to the patient. So it's much more complicated, and your IT system to track it must be very robust. If you don't, you're in trouble. Singapore General Hospital, my previous hospital, had a lawsuit because they promised to return certain incidental finding, and there was incidental finding. They forgot to return to the patient. Can happen, especially if a sample was collected 10 years ago and the research has been going on for the past 10 years. researchers forgot to inform the biobank couldn't have information, did not return, you get sued. So all these are implications that you have to keep in mind. Are you going to return? You don't return. The previous model, I said we won't return. Only on those grounds we take the tissue. If you want to return, thank you very much. Keep your sample. We are not going to take it. But if you're going to return, then you have to abide by the obligations, and all these are implications that we consider. What about if the patient has died? Well, but if it's a BRCA1 mutation, then the daughters may still want to know. My goodness, not only must you trace the patient, you may have to trace the patient's daughters. So the implications can be quite significant, particularly with hereditary disease. So you may need to have a mechanism for that. And by the way, you cannot just call a patient and say, by the way, your mother died 10 years, 15 years ago. We found that our research found some incidental finding which impact you. You cannot just offer. He said, who gives the right to contact me like this? Have I given you the right to be contacted? So you need to have that consent. Can I contact your daughters, your children about any incidental findings which may affect them? You must have that agreement to do so. So it's quite complicated. You have to think of all this and put that in the consent form. So for our previous system was easy. The donation model was very easy. That you use donation as outright gift, and this is driven by a lawyer. As a Coriolis principle, donors should not expect any personal direct benefits, blah blah blah, including medical condition, predisposition, or likelihood of such discovered in the course of research on the sample. Researchers and tissue bankers should not be under obligations to disclose such information to the donors unless they agree to do so in the first place. So we don't agree. We say we are not going to return to you. Very clear, and we don't have to return. But that was under the model of a tissue donation, which I love. Legally, that is clean and is easy to handle. This came out in our national newspaper, Research Dilemma, to tell or not to tell. And this illustrates all the issues which I have just mentioned before. The ethicists, of course, take a different view. The ethicist says that where there's possibility that there is clinical significant incidental finding, then the participants, the patients, should be allowed to decide whether or not they want to know of the results before they participate in the research. So they also need to opportunity to express their preferences about sharing this information with their relatives, their daughters, and so on and so forth. So the ethicist says we should keep it very open, discuss it with the patient. Do you want to know incidental finding? Do you want us to share with you? Do you want us to share with your relatives? All that before. But if the patient says yes, it comes with a whole load of responsibilities and liabilities. So considerations I already have mentioned that you need to consider this. And patients not to know, I mentioned that already. So this law and ethics, obtaining permission for tissue harvesting is an ethical rather than legal issue. The law deals with rights and liabilities, whereas ethics deal with right and wrong. This is the problem. When you're dealing with this question, if you ask a lawyer, the lawyer says, don't be stupid. Don't ever return incidental finding. From the legal perspective, it's about liabilities. You are taking on a lot of liabilities. So the lawyers will always say, no, don't take on more. The ethicists deal with right and wrong. So ethicist says it is right to return, but it is very difficult to our obligation to discharge. The ethicists don't care about that. The lawyers do. So there's always a struggle between the two, and you have to strike a balance between the two. Who will strike the balance? I think it's population sentiments. In a mature society, and here the society must be mature and educated enough to make the decision. The society will inform the national policy as to where do we strike this balance between patient rights and societal rights. If you go too much in terms of patient rights, there may be no research, and therefore there is no societal benefits. If you just think of the society and not individual, you ignore personal autonomy, which is also wrong. There must be a balance between the two, and this requires a lot of communication between the public, the biobankers, the hospitals, and so on. And this is a continuous process. The society sentiments may also change with time. In the past, our patients don't care about what you do with the samples. But as our society become more educated, they are beginning to ask these questions, and then the law may have to be changed to reflect that as well. So that was the first part, which I want to now continue with the second bit here. Can I? Okay. And the second part, I will spend a bit more time talking about these legal issues, ethical legal issues, as applied to Singapore and what have we done with the Human Biomedical Research Act. Now, many countries in the region do not have any established legislation that covers this. So this may be useful for you to see what another country has done, the considerations, the problems, the difficulties, and then you can decide for yourself as and when you want to have a law, if you want to have a law, and what should be involved and what should not be involved. The number one advice I would suggest is that all of you as biobankers be part of the process of writing the law. Our biggest mistake with our Human Biomedical Research Act, which is about to activate it, is that they only engage me after the bill has been sent to Parliament. And they already has been passed in Parliament. Once it's passed in Parliament, what can I do? I'll say that this law should have been revised this way, but now you cannot, it's already law. So what I can now do for the government is to try to come up with regulations, subsidiary legislation to interpret the law in a way to make it easier for research. But be involved in the writing of the law right from the start. Otherwise, you will find it very difficult. Once law is there, it's very difficult to change because Parliament doesn't have that much time to talk about so many things. So you may have a chance only once in 5 to 10 years to revise the law. So you really need to be part of this early. So we talk about a few things. Ownership. So I mentioned this about the ownership, but no property in a dead body or parts thereof already. And as I mentioned earlier, this is the Kelly case. So the two pieces of legislation, I got a bit confused earlier. So the first one is John Moore. John Moore is the one who basically of the hairy cell leukemia case, where basically he tried to sue the hospital or the university for selling hairy cell leukemia cell lines without his permission. So basically he doesn't have rights. But this important point here to note is that the court ruled that while John Moore did not have property rights, he basically says that John Moore should have a right to decide what to do with the samples. And the court also said we do not purport to hold that excised cells can never be property for any purposes whatsoever, meaning to say that there are situations where those cells may have property. And the common law rule is that it can be property if those cells has been altered in some way. And this is now enshrined in our Human Biomedical Research Act. The spleen that you take out from the patient, from hairy cell leukemia patient, that spleen has no property rights. Once I make it into a cell line, it is property. So it has property rights once I make it a cell line. So at some stage, it changes from no property to become property. So you have to decide by legislation or whatever, at which stage it is property, which stage it is not yet property. In Singapore, if you freeze the tissue, it's not enough. You dissect the tissue, it's not enough. It's still human tissue, it's not yet property. You have to alter in formalin, that's property. You make it a cell line, it's property. You put it into a xenograph, it is property. But if it's just dissection, centrifuging it, dissecting it, all that is not yet property. Now, this other issue is the famous case I mentioned you about Kelly, who stole the tissues from the Royal College of Surgeons, and the position here is that once the specimen has been frozen liquid nitrogen, it is property and belongs to the institution. But that is UK position. But in Singapore position, freezing it is not enough. You must put in formalin. Freezing is still not enough to make it property. So this is something that your country has to think of about where is property. This is still an ongoing debate. If there is, I'll move beyond this. The legislation. This is the part I want to talk more about. The legislation that impact biobanking in Singapore, two pieces of law. The first piece of law is the Personal Data Protection Act of 2012. This covers the use of personal data. The second piece is the Human Biomedical Research Act of 2015. The PDPA 2012 is fully implemented. The HBRA is partially implemented. The last bit about tissue banks will be implemented in the middle of this year. And what in this, the HBRA defines who is a biobanker. Now, a lot of people say, I'm not a biobanker, I'm a surgeon. I just keep some tissue for my own research. So a lot of people say that I'm not a biobanker. Now, a biobank under the law refers to an individual or body of individuals, whether corporate or unicorporates or any other organization that carries any kind of biobanking activity. Basically, an individual or body or organization that carries on biobanking activity. Now, what is biobanking activity? Biobanking activity refers to a structured, organized activity involving human tissue for the purpose of facilitating current or future research for public health or epidemiological purposes or any combination, including any of the following activities. 1. Collection, storage, procurement, importation of human tissue, supply, provision, export of human tissue. So essentially, if you collect tissue, store tissue, process tissue, give out tissue to support research, you are a biobanker. I don't care whether you collect one piece of tissue to facilitate research or 1,000 tissue, you are a biobanker. Whether you are one person or a whole organization, you are still a biobanker as long as you satisfy these criteria. The only exclusion, however, is that it excludes an individual body of persons that collect samples just purely for my one IRB approved research. So if I collect sample for this particular research approved by IRB, you are not a biobanker. But the moment you give it to another person, you are a biobanker. If you use it for a second or third project, you become a biobanker because you are facilitating future research. So this is how our current law reads it. This exception was given to make it less painful for some researcher who only collect sample for this one project. They don't want to go through the documentation needed of a biobank because they're not distributing to other people. But remember that with every time you got this exception, people will see that as a loophole and they will try to duck through it. There are people who basically say that I'm not a biobank because I have one study for my own, or my one study that's approved by IRB is my own study. What is the nature of the study? What samples you're collecting? I'm collecting all human tissues. Huh? What kind of research is that? My research is to human diseases. The whole, and basically who is involved in the study? The whole hospital. They're all my collaborators. They are using this loophole to say that I'm not a biobank. It won't work. So basically, there are people who try to do that. So every time you do law, remember, every time you give an exception, you spend a lot of days thinking about it because everybody will be thinking how I can use this loophole to get out of the requirements. So that is the issue. So example, Dr. A is a hematologist, performed bone marrow aspirate. He has stored leftover tissues for research by his hematology colleagues in Singapore. B, he's a physician, collects blood from his own diabetic patients for his own IRB approved research. C, he's a head of pathology department. He has leftover tissue samples from different surgeries and he provides it to researchers. Who is a biobanker? All except B. B is not a biobanker because he is collecting for his own IRB approved research. Dr. A, he collects it for his research, but he uses it for other researchers, for other people. He is actually a biobanker as well. So we need to be very clear, at least under Singapore law. So our people need to realize that. And if you're a biobanker, what does it mean? You have to notify the Ministry of Health before you start any biobanking activity. I'm a biobank. You have to annually declare compliance. You have to report serious adverse events. You have to exercise supervision and control, including formulating policies, SOPs. So those are things we will check. Do you have an SOP in place? What is a policy in place? And you have to appoint a person in charge. This is the person who goes to jail if anything goes wrong. And this person takes responsibility to ensure the policies are complied with. You need to have a system to track consents. So essentially, as an enforcement, I can go to your biobank, take out a piece of tissue, show me the consent form. And I can also look at the samples that you issued before or published, and then I say, show me the consent form for that. You must be able to produce it. Research, release of tissue for research, whether it's identifiable or not identifiable, you need to have different levels of approval by a tissue bank or scientific advisory committee. If you're sending samples overseas, then you need to have consents. The consent must cover the transport of tissues overseas. Does the patient agree for the sample to be sent overseas? Secondly, you need to have a legally binding letter of an undertaking or contract that says that the receiving party will abide by the HBRA in Singapore with respect to the samples that they have received. So they have to abide by Singapore law where that's concerned as well. What happens if we import tissue? Can you get samples from Korea and other countries to do research in Singapore? Now you can say that, well, the laws only cover Singapore with regard to samples that is obtained from Singapore. What are the samples obtained from overseas? We also feel that although we have no control over the laws in other countries, we also don't want their patients to be exploited. So we say that the minimum requirement is that the samples to be sent to Singapore for research must have patient consent. We do not require the consent to be according to our standards. We say that the consent should be in keeping with the standards in the country of origin. But if they say that this consent is taken in accordance with Korean law, Japanese law, Malaysian law, we will accept it. We have that letter. But there must be consent. You cannot be taking samples from countries where no consent is required. That one, we want to protect their patients as well. Although their own country government, of course, has the primary duty for that. Now, what's the scope of PDP and HBRA? Personal data. What is personal data? Personal data refers to data whether true or not. Does not matter whether the data is true or not. About an individual who can be identified from that data or from that data and any other information to which the organization has or is likely to have access. Meaning to say for the hospital, all the data kept in the hospital is personal data, because even if you code it as a biopsy number, clinical hospital number, you can link it up to the patient's name and identity card in the hospital system. So you have access to the linkage, it is personal data. But if you transmit it to somebody else who has no access to the linkage, then it's not personal data for the other person. But for yourself, it is personal data. Similarly, HBRA does the same thing. The Human Biomedical Research Act has a similar definition of individually identifiable. If you can identify the sample from the tissue itself or from any other information that is known of the tissue. Now, you know what is identifiable and not identifiable is always a question. For example, would you ask, I give you a next-gen sequencing data, is that identifiable or not? ATCG is not identifiable. Yes, it's true, but sometimes if I have some other information that is relevant and they can identify that data, that genetic data may be identifiable. Now, I'll give you an example. If I were to give you just a genetic sequence, ATCG, without any information, obviously it's not identifiable. Now, if I say that this is a sample from a patient with motor neuron disease, well, it restricts to a smaller number of people in the country as motor neuron disease. Maybe you can say not completely identifiable. If I say that this actually comes from a famous physicist with a motor neuron disease. Oh, not many physicists with motor neuron disease. If I say that this is come from a famous physicist with motor neuron disease with interest in astrophysics and you practically know that it's going to be Hawking's. So, in other words, the more information that is linked to it, the more likely that if this piece of data may become identifiable. And you yourself may not have given this identifiable data, you just given a sequence, but you link that sequence to a study. And then somebody else from that study has other pieces of information that can contribute to it and that can together link to the sequence of the genetic sequence and make the genetic sequence identifiable. So this is the problem. When dealing with this, the biobanker has to consider, by giving you this information, is it possible for you to link it up to other means and identify the person? If it is, it can still be personal data. So that's something you have to think about. What is, this bit's our adjunctive law. Now, one of the things that's excluded from human tissue under our law is, under the first schedule, body fluids, waste products, saliva, sweat, urine, feces are not considered human tissue. Hair shaft without a hair follicle is not considered human tissue. Human biological material that is not individually identifiable but has been processed in such a way that its functional, structural and biological characteristics are substantially manipulated as compared to the time of collection are not human tissue. What do you mean by this bit? So this bit refers to samples that are significantly altered. For example, FFP material, they have been significantly altered. If they are de-identified, they are not human tissues. They fall out of the HBRA. So all the paraffin embedded material pathology department, they can be used for research without consent, provided that they are de-identified. Cell lines are derived from human tissue, but they have been altered significantly under our law. You can use it for research they are not human tissues. You can sell them even because they are no longer human tissues. They can be sold and purchased as long as they are not identifiable. So we have that in our law. You have to decide. Do you want to be so strict? Everything is human tissues, then of course it also stifles research. If everything is too liberal, it's also not good. Where do you strike the balance between the two? For us, significantly altered and not identifiable is a lower risk. We consider that outside of human tissue, outside of human tissue, the HBRA. Now, the following is not considered substantially manipulated. I mentioned all those in blue. These are not considered to be substantially manipulated, so they are not in the system. They are still considered human tissues. Issue of consents. Under the PDPA, organization must inform all the data subjects of the various purpose for which it's using. In other words, if you want to use a patient's clinical data, the patient needs to know. The patient needs to know about that. Those is now enshrined by law. So consent form needs to be broad, generic, and provides. In the past, consent was very broad. So this is a big change under the PDPA. In the past, our PDPA tends to be like this. I use a consent to the use of a tissue for RB approved research. And this could be just an additional sentence in the consent form for operation and may be taken by the surgeon performing the operation. That was in the past. All that is not allowed. Number one, the surgeon doing the operation should not be the one taking the consent. Number two, the consent form for donation for research must be separate from the consent form for operation. Patient must not be confused between the two purposes. And number three, it cannot be so simple. One line, I agree or not. So therefore, it has to be different. And what is the difference right now? Consents under the law, Section 37 of the Human Biomedical Research Act says this. First, there must be appropriate consents. What is appropriate consents? I will come down to it. Consent, can it be broad or can it be limited? Now, broad consent means consent for many different kinds of research, including future research. Limited research consent means for only this particular research. The disadvantage is that you need to re-consent every time. Our law allows both. A law allows you to give broad consent. I allow the sample to be used for all kinds of RB approved research. Our law allows that. And I think that makes sense because the cost of reconsenting is very high. So it makes sense if the patient has no issue, let that be a broad consent. Some of our ethicists disagree with broad consent because they're ethicists. So ethicists say that I can only consent to what I know. So if you tell me I want to use for this research, I can decide yes or no. But if you tell me that I want to use it for all future research and you have no idea what research it is, how can I consent ethically? I don't have full information. So there are ethicists who feel that broad consent is always wrong. In Singapore, we weigh the two. We decide that yes, we will allow broad consent. That is, we weigh the balance. But for your own country, you have to decide, will you allow broad consent or you say always must re-consent, narrow consent. So, as I said previously, in our old consent form, it was very narrow, just a single line like this. What is now present in our new consent form? Our new consent form has A to O, multiple paragraphs. So you have to ask, for example, is the research that you want to use this tissue for, is it a specific research or is it general research? We allow broad consent for all RB approved research, or is it meant for this particular research only? You must explain to the patient. Will this tissue be only used for research or can it be used for any other purpose? For example, will that tissue be used to make into heart valves? Will your tissue be made into cell lines, commercial products? Will your tissue to be made in organoids for testing of new drugs? If it is, you must explain. What is the proposed area of research? If your research is specific, not general, you don't know which area, but if it's for one particular research, you need to know which is the purpose of the research. What kind of research is this? Will this involve animals? Will it cancer research? Is it just basic science research? So you need to give some idea of what is the purpose of the research. Compensation. If you undergo a procedure to take out the samples, this doesn't happen for tissue because tissue is when you have to take out a tumor anyway, so that's different. But what happens if I take blood from you? And if the cause of taking blood, I cause any injury? Compensation. Is there compensation for injury or not? You poke one time. What happens if you poke 10 times to get blood from me? Will there be compensation or not? Do I have the right to withdraw consent? Now I told you that in our donation model, no right to consent because it's a donation. Now HBRA says cannot have donation model. It must be by permission. By permission means to say that you have a right to withdraw your consent at any time. And what happens when we withdraw consent? Our law says that if we withdraw consent, if the sample has not yet been used, the tissue will be destroyed, not will be used. If the tissue has already been used, then whatever data that has been generated can be published. You cannot, but we will not use it for future research. So that is what our law says. Again, you have to think, what do you do if you say you are allowed to withdraw consent? What are the implications? Will you use will there any identifiable data? Let's say the patient say, I allow you to use the tissue and the data in an identifiable form because you need to trace follow-up data. So you need to know who it comes from so that I can know follow-up data. So you want to use the identifiable form. Will I know whether this identity, this information will be used for future research or only for this research? Will I be re-identified for incidental finding? I just now talk about incidental finding. You see, if you say that I will all the tissues to be used in a de-identified form, which is the general purpose, the general rule is that all samples must be de-identified for research. But if I find incidental finding, will I be re-identified? So you cannot just re-identify yourself and give it to the patient. You must ask the patient at this stage, when the patient is donating the tissue, do you want to receive incidental findings, if there are incidental findings? And if you say yes, that means you need to be re-identified, otherwise I cannot trace you. Do you agree to be re-identified in the event of incidental finding, to return incidental finding to you? Do you agree that we return incidental finding to your relatives if they impact your relatives as well? All that must be discussed in the consent. You need to renounce all rights and IP. Our law put it as a requirement. If you want to take samples for research, you must explain to the patient that if you donate this tissue for research, you must renounce all commercial rights and IP with regard to the donation, to the samples that you have donated. Do you agree to that? You must. If you don't agree, you will not take that tissue. Will the tissue be used in an individually identifiable form, or will the tissue be de-identified? How do you, the patient, feel? Do you, a patient, agree that yes, you can use my tissue, but only if it's de-identified, or you allow the tissue to be used in an identifiable form so that we can trace follow-up data? Which one it is? You must explain, and patient must agree. Will you allow the tissue to be used in restricted research? So Singapore law has a whole list of restricted research. These are more controversial research. What kind of controversial research? Where you put human tissue together with animal tissue. This kind of hybrid kind of work. Singapore law does not allow the, you cannot clone human, you cannot try to make any sentient beings. So even if you've got an embryo, you cannot pass certain stage of development. But we have a list of prohibited research that one China scientist tried to do recently. Those are prohibited, not allowed. Then we have restricted research, which are highly controlled. You can put these tissues into embryo of animals, put cell lines, human cell lines to embryo of animals to certain stages and things like that, but those have to be controlled. Certain passages and after that not allowed, and things like certain levels of maturity, they're not allowed. These are what we call restricted research. But patient needs to give the permission. Do I allow my samples to be used for this kind of restricted research or not? So that's another component. Do you allow your samples to be exported overseas or not? So you can see the consent form is now quite complicated. It is not just yes or no, it's a whole list. And it's no longer 1 second, 1 minute, it's an hour or longer to explain to the patients. Now, your patients may not all be very well educated. And you have to explain the patient incidental finding, restricted research. Can the patient understand? If the patient does not understand, the consent form is not valid. So you need to get the family there. Explain to the family, the father, the son, the parents, the wife. explain all that, not enough, give them the brochure, you read about it, tomorrow I come again. Do you have any questions? You don't understand, let me explain this again. Are you clear? Do you have any more questions? You want to think about it? Okay, you can think about it. Operation done already, never mind. After operation, then we come back again, you can take retrospective consent, and then you have to go through a process until you are very clear. The patient must have every right to ask questions. And then, to make sure your consent is valid, we also audit the consent. After consent is taken, we will go back to the patient again. Do you understand what you have done when you signed this? Do you understand what this clause means? To make sure that the person taking the consent has done a good job. So it is very expensive procedure in order to do so. So I think that's something you have to keep in mind. The other bit, what happens if the patient is dead? Consent in the case of deceased patients. What about autopsy specimens and so on? PDPA, our law, does not apply to personal data of patients who are dead for more than 10 years. So personal data is only personal data of living persons and 10 years after his death. More than 10 years after his death, his personal data, name, IC, is no longer considered personal data. This is Singapore law. It may be different for your country. You can decide where you strike the balance. Tissues, more strict. For tissues, you need to take consent from the patient. If the patient is dead, you need to take consent from a hierarchy of social proxy. First level, ask the wife. Second, ask the father, the parents, or the sons. Beyond that, the uncles, the niece, and blah, 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 one whole long list. First cousin, second cousin. And so you have a list, hierarchy, you go down the list. You need to take consent from social proxies. This becomes a very important issue, partly because in my country we have a lot of Muslims, and our Muslim community is very sensitive to some of those things. We have some Muslim women who say that I cannot decide. My husband's decision is more important than my decision. So we also need to consult, and we have to be consultative. No problem, we're happy to speak to your husband. You speak to husband, we come back again tomorrow, the day after. You need to have all to buy in. So that's also quite important. Now, next, waiver of consent. Do you ever say we waive consent? Now, this was a very popular mechanism. Waiver of consent sometimes is absolutely necessary, so therefore we do have that, but you must be very cautious. If 100% of your samples are used in research with a waiver of consent, something is wrong. So therefore, we need to strike the balance between the two, and that is a concern, a waiver of consent. Now, with regard to data, we talk about data, then we talk about tissues. Regarding the data, Personal Data Protection Act does allow a waiver of consent when it's used for research, but they need to satisfy certain criteria. What are the criteria? The research purpose cannot be reasonably accomplished without the personal data being provided in the individually identifiable form. It is impracticable for the organization to seek the consent of the individual for the disclosure. What do you mean by impracticable? They tell me that impracticable is different from impractical. Impracticable is almost impossible. So there's impossible, there's impracticable, and there's impractical. So impracticable may mean to say that the patient is still alive, okay, so you can still take consent, but the patient lives in Zimbabwe. And I don't know where in Zimbabwe. He's a missionary ministering to the tribes in Zimbabwe. I don't know where he is. How am I going to take consent from him? Theoretically, it is possible, but it's it's very impracticable for me to take consent in this context. So the patient has emigrated. He's left Singapore. He's given up his Singapore citizenship. He's emigrated to US, and I don't know where he is. It's impracticable. So in other words, the level of difficulty is very, very high before you can adopt this. To say that it's expensive is not sufficient as impracticable. The personal data will not be used to contact persons to ask them to participate in the research because you are asking for a waiver, so you should not be able to contact. You can contact them, they should not be asking for a waiver of consent. And then finally, the linkage of the personal data to other information will not harm. By linking this personal data, by using it in an identifiable form, it will not harm the individual. For example, what sort of data are you going to review or going to share that's in an identifiable form? You tell me HIV status, immediately no. Because revealing personal data that is HIV related may harm that particular person. So therefore, it cannot be. So you have to explain to the IRB that this information will not harm the individual. And the benefits to be derived, there's a risk, which is the leakage of personal data. On the other hand, is the benefit. What is the benefit? The benefit must be that is clearly in the public interest. Now this is question about what is clearly in the public interest, and we are still debating about it in Singapore. In Singapore, when we first started, the government is very strict. Public interest is only referred to large epidemiological study that benefits the entire population of Singapore, hundreds of thousands of people, then it is in public interest. But the kind of work in research, you can't say it benefits a whole lot of people, so may not satisfy. But then we now argue that, hey, but if I do research that benefit patients with Huntington's chorea, it's a very small population. But for patients with Huntington's chorea, it is clearly in their interest. Don't tell me that they are not of public interest. It is still in the public interest, even though it's a small segment of that public. So this is an ongoing argument that you have, and now the government is now changing its mind about that. What is considered public interest is now widened, so that you don't penalize minorities, because we say that if you define so broadly, you actually penalize small populations who will be discriminated against. So they took our argument, yeah, that makes sense too. So therefore you have to broaden in that sense. So you need to have that communication. So the conditions for waiver of consent, the IRB must, same thing, human tissue the human biomedical, for human tissue, requires the same requirements. You need to involve no more than minimal risk, no procedures for which written consent is ordinarily required. It must practicable, must not be practicably carried out unless there's a waiver. That means impracticable. There's no more than minimal risk, it will not adverse the right and welfare of the research subject, and it must be for the greater public good. So whether it's the waiver of consent for data or waiver of consent tissue, the same principles. Must be for the greater public good, and you cannot do this without that waiver of consent. Quite impracticable to take consent. Must be very careful. The moment this came out, I've got thousands and one people who say that this is impracticable. To contact more than 50 persons is not practicable. You know, you have to be very careful, because everybody will find as a waiver what is impracticable. And somewhere you have to make a judgment call. Contact 50 persons, I wouldn't say that's impracticable. What about 500? What about 5,000? What about 50,000? What about 5 million? At which stage does it become impracticable? It's not easy judgment call. The IRB has this poor responsibility. The poor chaps there has to decide, weighing the benefits and the risks, what is impracticable? Will you allow a waiver of consent? Legacy tissue. What about samples are collected in the past before the law came into act? What do you do with those? The law in Singapore says we need to have an escape valve for those samples collected in the past. So we say that samples collected in past, if you have got, if they are de-identified, then of course they can be used without research. So if you've got samples that are taken from past, but if you're de-identified, they're not identifiable, then no consent, you can also still be used. This is a problem because we have got tissue banks and surgeons who have collected samples for the past 30 years. And it says, 30 years ago, where got consent? 30 years ago, we just do everything we like. Nobody has the issue. The ethical standards then were different from the ethical standards now. So we have our escape valve. We say, okay, you can still use those tissues, you don't have to throw them away, but you must de-identify them. So that was a requirement. What about imported tissue? Can you import tissue? I already mentioned. We say that you can import tissues from overseas, but we want to protect their population to some extent. We think as a human being, we have an obligation not to let anybody get discriminated against. You have to make sure that there's consent in keeping with the standards of that country. Paraffin embedded material in pathology department, can they be used? I mentioned that already. As these are considered significantly altered, so therefore, as long as they are de-identified, you can use them without consent. And this is also in keeping with the policy and the laws in the US. In the US and the UK, as long as paraffin embedded material are de-identified, they can be used without consent. So that is also the same case in Singapore. In your country, you have to think, do you allow that or not? So this is the practice in the USA. Now, USA is very interesting because in recent years, we always say that the ethicists are strongest in Europe. European ethicists are the strongest, very, very strict. US not so strong, but in recent years, the ethicists in US also becoming stronger. So therefore, the common rule, there's a common rule, which is the old rule here. This is the rule in the US all along, that you can use paraffin embedded material, these stored samples from previous studies, without consent if you strip them of personal data. As long as de-identified, you can use them for research. However, the College of American Pathologists had recommended that patients should be asked to indicate if they opt out, because some ethicists say that's very unethical. You just use their patient's material without consenting. Isn't that unethical? So the CAP says that, well, you let the patients know, this is what we do. We will use your samples for research without your consent, but we will de-identify them. If you're not happy, you can opt out. Let us know, and we will not use your samples. That's one way of dealing with it. The ethicists are still not happy. So the US say that this is not ethical, so they propose a change in the rule that covers biobanking in the US, which they call the final rule. Now this rule basically this is a proposal. At that time, they recommended a change in the law. And the law that they were going to say that this law, they would basically require researchers to obtain consent before a patient's non-identified specimen is used for research. Basically it says, de-identify not enough. Even you de-identify, you still need to take my consent if you want to use for research. So they proposed this change. But good thing was that they this final rule was not, this clause was not allowed. In the very last week before President Obama left office, he struck off this clause and signed it into law, which means that the current final rule still follows the common rule, which is as long as de-identified, you can use it for research without consent. I think that is a very logical position. And thankfully, because I think the position that you need to take consent for everyone is going to kill off a lot of research, and I don't think that's in the interest of the public. We have this responsibility. We have a responsibility to the patients. We also have a responsibility to the wider public. We need to strike a balance between individual rights and societal rights. Who can harvest tissue for research? This is very clear. In the past, surgeons like to think that I'm there operating, I have every right to take every sample I like. The Human Biomedical Research, the Singapore Bioethics Advisory Committee says you cannot. It is the diagnosing pathologist that must take the samples, because we have to make sure patient care first. It does not compromise the diagnostic integrity. Our Act now put it into law. First, it was the guidelines of the Bioethics Advisory Committee, but now it's now enshrined in law that say that no sample can be used for research unless a medical practitioner or the healthcare institution responsible for medical care has completed all necessary therapeutic diagnostic procedures and no longer requires it the tissue or part of the tissue for treatment. So this is an important component. What about incidental research findings? How does our law deal with it? Just now I talked about the difficulties with incidental finding. So how does our law deal with this? There are different kinds of incidental findings. Findings that are donated by normal person found elevated blood sugar. Those are affect the patient actionable. I think for this, no question, we should return the incidental findings. Findings that are not currently actionable, meaning to say a GWAS study find that a person has a higher risk of Alzheimer's disease. You can't do anything about it. Should you return the finding or not? Controversial until now. Because you say that it's not actionable, we don't have an obligation to return. Hey, but then for a person who is, I'm a tycoon, I'm a multi-millionaire, richer than Donald Trump. I've got 10 sons. I'm trying to decide which son shall succeed me. I want to know which of my 10 sons have Alzheimer's disease, this gene that carries higher risk of Alzheimer's disease. I don't want the fella who is now 30 years old carries the risk of Alzheimer's disease to succeed me. To me, that's very significant. So it may be not significant to you, but may be significant to another person. Very difficult. What is significant? And as I mentioned, it may affect your relative. So all these are difficult decisions. So what sort of incidental findings to return? What is significant and actionable findings? What is not actionable now, may be actionable later in 10 years' time? Now these are questions that the US, with the common rule deciding on the revision of the common rule, which is now the final rule, they were deciding as to what to do this. What does US do? The US has a list of, can't remember, 29, or now the number will continue to increase. They decided on a list of what a group of wise men decide as right now clinically actionable significant findings. You must return the following. Then those which are not in the list, you don't have to return. So this is what the US does. But if you do this, you must continually review that. There are always disadvantages, but that is what they do. It's one way of dealing with it. In Singapore, what do we do with incidental finding? Number one, our law does not require you to return incidental finding if you do not want to. Meaning to say, and this is from input from me, we say that I mentioned to the committee that we shouldn't make it too onerous. So we say this, that the biobank has to decide whether you want to return incidental finding or not. And the researcher has to decide whether you want to return incidental finding or not. The law does not require you to return incidental finding, but the law requires you to have a conversation with the patient as to whether the patient wants incidental finding to be returned if incidental findings were to be provided for in the project. So the project can basically say that we will not return incidental finding in this project, in which case your conversation with the patient is that this study will not return incidental finding, do you want to participate or not? So you have that conversation. If the research project says this trial will return incidental finding and these are the type of incidental finding we will return, you must engage the patient. Will you return, do you want incidental finding to be returned to you in this project, which will allow incidental finding return if you want it? Then you decide. The patient says yes, you have to track and you return. Patient says no, you do not return because the patient has declined the return of incidental finding. So this is what our law does. The point here is information to the patient. Patient decides. You are not required to return if your project does not want to return incidental finding. So we do not make it a requirement for the project to return. Ethicists are not not happy with this position, but we are balancing the risk and we take this position. The ethicist has given to us additional problem. They say, the patient says, your research, you will return incidental finding if you want it. The patient right now says, no, I don't want to know. But when you have the incidental finding, you realize that this incidental finding may mean life or death for the patient. Shouldn't you tell the patient that, hey, when you make the decision, are you out of your mind? Because you should know about this. This is data that can save your life. And it's something that is very simple that you can do. Are you sure you don't want to know? That becomes a problem. Patient already said, no, I don't want to know. But the ethicist says, maybe patient doesn't fully understand the implications of that decision at that point because he doesn't know what information you'll find. But now that this information is found, do you need to engage it? This is a problem for the RRB. In that situation, the RRB has to decide, do I need to recontact the patient and tell the patient that, look, do you want to invite the patient to reconsider his earlier refusal in the light of new information that the RRB feels is so significant that the patient is likely to change his mind? This is something that the RRB has to decide very hard. Here we are balancing autonomy of the patient. I already told you I don't want to know, versus the feeling that the data is so compelling that any ordinary person should want to know that. That is a very difficult decision. IRB have to decide, and if IRB feel that we think it's ethical to invite the patient, we don't return immediately. We invite the patient to reconsider the position in view of additional information. If the patient still says no, fine, I've done my job. If the patient says yes, now I changed my mind, I want to know, then you have to return. So this is what the law does and how we deal with it in Singapore. There is no right and wrong answer. There is no perfect answer, but every one of us have to think through what we want to do in this situation. Finally, I want to talk a little bit about this issue. I started today's talk with the first slide that says that biobanking is one of the 10 things changing the world right now. That's the excitement with biobanking 10 years ago, where it's the sexiest thing in town. Now we have this article published 2016, has the biobank bubble burst? Withstanding the challenges for sustainable biobanking in the digital era. Bottom line here is that people are now recognizing biobanking is a very expensive process. Is biobanking achieving, is it fit for purpose? Is it achieving the aims that you started off with or not? So many people rush into biobanking, like people buy stocks. Stock exchange, stocks goes up, everybody rush in and start buying it. I remember a story in a Singapore newspaper before the biggest bubble burst many years ago, that even the shoe shine person was asking his customer, "Sir, have you been buying stocks, this particular stock?" "I bought some too. I heard that it was rising so high that I also bought some." This is the danger. If the shoe shine boy also starts buying stocks, it means to say everybody is jumping to it without thinking about it. It's only a time before its bubble is going to burst. And sure enough, it's coming. A lot of people have been asking serious questions about biobanking. And the biggest question is, how do you sustain how to ensure financial sustainability of a biobank? And as I said, to the funding agency will ask you, can you make sure that your biobank is financially sustainable? The quick answer is no, there's no way it can be sustainable. But then how am I going to throw money into this forever? Every year I throw in $1 million to your biobank. Can I afford to do that? And just now we saw that in Japan, of course, the investment is even greater. And it's true. How many years can I continue investing $10 million a year? Will I be able to get back the return on investments? That is a question. So why are biobanks not sustainable? Number one, biobanks are often provided with seed money to start. They never think about maintenance. Researchers are given a grant. I got no problem with biobanking, I got money. I got a big grant. But the grant lasts 3 years. The grant lasts 5 years. And then you want to store the samples for how long? Oh, this is a cohort study for what? 25 years. Where are you getting money to maintain for 25 years? I don't collect cohort studies. I say that you want a cohort study, you want to maintain for 25 years, show me the money for 25 years, then I'll collect for you. Because how else can you be sustainable? So this is a big problem. Secondly, there's an optimistic belief that there will be future funding. You know the idea of too big to fail? Oh, the government has provided $10 million already. Every year $10 million. Too big to fail. Surely in the future they must maintain. They cannot lose the investment. They already invested $100 million. You think they'll let us close? That is another fallacy. That is not right. Too big to fail argument. And I show you the Singapore National Biobank. It closed. The government put in 10 million, but Singapore government has a very low risk appetite. After $12 million and after 8 years, they realized that, hey, this one is not going to be sustainable. The government quickly says, no, cut or loss. So you have to think, but Singapore is a small country. We don't have that much resources. We have to be very careful with every single cent we spend. So that's something to keep in mind. Third, there's unrealistic expectation. Cost recovery will sustain operations. No problem. The biobank, you can recover the cost by charging the researchers. But I told you there's only a small subset of samples collected that will be requested for research. Oh, historically it's only about 10%. And you cannot make that 10% pay for the remaining 90% of samples. So that is not sustainable. And if you want to force them to pay for the 90%, the researchers cannot afford the high fees. So their grants are limited. The grants money is not enough. They cannot request the samples. If they don't request the samples, less of your samples are being used. Less of the samples are being used, less revenue coming, you got a downward spiral. So that also cannot work. So what do we do? How do we solve these financial sustainability issues? Let's sell tissues. Can you sell tissues? Commercial biobanks are doing very well. They buy and sell tissues. Now, it depends on your country. Is it ethical to sell tissue? Many countries think it's not ethical. In Singapore, you cannot sell tissues. First of all, tissues cannot be sold because there's no property in human tissues. But if you sell tissue, it is prohibited by law. 2 years imprisonment for anyone to try to sell any human tissues. This is an old law, the HOTA, our new law in the Human Biomedical Research Act says it is an offense to sell any tissue. Anyway, such a contract is not respected by law. Secondly, if you try to sell tissue, you will be imprisoned 2 years imprisonment. If you encourage someone to sell tissue, also a crime. If you fake and hide it under some other mechanism by actually selling tissue, you will also go to prison for 2 years. So we make it a very serious offense to do that. So you can't. And this includes tissues, organs, or blood. But this does not include samples, tissues which are significantly altered and de-identified. Cell lines which are de-identified, they are not human tissues. Yes, you can buy and sell. Paraffin embedded material not included in this. But cells of the tissues which are identifiable, paraffin embedded material or cell lines still identifiable, they are all human tissues. You have to be de-identified, number one. Number two, they must be significantly altered. So these two criteria are necessary. So the law basically requires this, and basically, I just noticed that they've changed it. They make it more stringent. HOTA, 2 years imprisonment. Human Biomedical Research Act, 10 years imprisonment. Very, very strict to make it very clear that nobody does that sort of things. So I think Singapore takes a very strong argument, and we make it very clear that we don't want to be the hub for tissue selling. So that's something absolutely we do not want. So you cannot sell tissue, you cannot recover costs from the tissue. What else can you do? Well, we provide tissue research services to recover some costs. Because as part of the QC, we need to histology, we need pathology expertise, we need to do immunohistochemistry. You saw my annotations. We perform FISH, we perform sequencing. We want to know whether the tissue belongs to this patient or not, or is it contaminated. So we do STR analysis. Now all these services or expertise can be used to support research and sometimes even clinical services. So we perform immunohistochemistry for researchers, double staining for researchers, we do immunofluorescence labeling, and we charge the researchers. We combine IHC, ISH techniques, we create tissue array, we can provide tissue array sections, tissue array blocks, those you can sell. They are de-identified, they're significantly altered. We perform tissue laser micro dissection, FISH, ISH for patients, and so on and so forth. So all these are services we provide. We can perform cellular array from the tumor, fresh tumor, we strip cells, and then we make it into cell suspension, make it into a cellular array so you can screen for lots of markers. So these are research services. We earn some money from it. Sometimes you earn more money from research services than from biobanking. And that's not surprising because biobanking, you cannot charge too high. Our law is so strict. You cannot say, I give you tissue and I charge $100,000 per piece of tissue. Number one, nobody will pay. Number two, the law will say that you are selling tissues. Don't tell me that 100,000 is for recovery of costs. How much of your staff is involved? How much they'll look at your time. How much time of your staff is required to provide this section? What is the salary of your staff? Your staff is paid $1 million salary. Just based on salary of your staff, calculate by the number of hours, this tissue will only cost $300. Then you cannot charge more than $300. Anything more than that is not cost recovery. That is profiteering. So we have to be careful about that as well. So research services, no problem. You can charge research services based on market demand, market rates. This is a case where we use STR analysis to determine whether this tissue really belongs to this person, whether it's contamination. But sometimes there's clinical usage as well. This is a case where the histopathology department requires our services because they got a sample where it is all benign endometrial tissue, and then there was a little speck of tissue which was endometrial carcinoma. But the problem was that when they tracked through it, they found that the samples that were trimmed that day, there was an endometrial carcinoma case that was trimmed before this current sample. Was this contaminant carried over on the cutting board that didn't quite clear, or was deposit from the patient that the patient has a small bit of endometrial cancer. Very important. So how do you know the difference between the two? So we perform ST analysis. You can see that there's a chimera here. There's additional bands indicating very clearly it belongs to somebody else. These two bands belong to the patient, and this additional peak here belongs to somebody else. So you can tell that there's a contaminant. So by providing research services, we can earn some money. Next, quickly about standardization of biobanks. So here, I want to quickly mention about ANRRC. The Asian Network of Research Resource Center, I'm the chair of the Biobanking Committee. We as an organization, as an academic educational organization, we stand to try to practice a common standard among biobanks. We try to raise the standard of all biobanks, and we want to practice a common standard. This whole morning we'll talk about standardization. So what standards are essential in human tissue biobanking? There was an earlier question asked to me also about the standards here. So if an accreditation system is introduced, what should be the basic common standards? And here, as a regional body, we don't want to be too ambitious. You set the highest standard, you put up the highest, the ISO 20386 or whatever. The problem is that many people cannot afford it. It's too expensive. So we want to be pragmatic, to be useful. So we basically come up with some common standards, and for a start, we do a survey. Every year at our ANRC meeting, we ask the different countries, share with us the answer to your following questions. So we'll try to see how we can move towards standards for sharing of resources. The whole purpose of standards is to enable better sharing of resources. So first of all, do you allow sharing of resources? So different countries have different rules, so we need to clear. By the way, these answers are always very changing. For example, with Japan, at that point in time, we don't have any biobanker, human tissue biobanker. And Professor Obata mentioned that it may be restricted only to Japanese scientists. It's not very clear because every biobank have their own rules. So they may not be standardized even in their own country. So we need to know that. But what are the common standards? Now, to be a member of the Biobanking Committee of ANRC, we agree that as a group, we will agree to some basic common standards. As to be a member, we sign up to the following, very basic. Number one, we must have a consent procedure. It can be limited or universal, it could be a permission to use or absolute gift, but we must have a consent. We will not allow a member of the ANRC Biobanking Committee if they say we take consent, we take tissue from a patient without consent. By the way, some biobank has mentioned to me before, in my country there's no requirement to take consent. We don't allow that because I think that's not ethical. Next, there must be a standardized collection protocol to ensure minimal ischemia time and documentation of specimen statistics such as the ischemia time, how long has been kept in warm ischemia, cold ischemia, whether it's tissue is tumor or normal. There's some histology to ensure that this what you collected is tumor or normal. So some standardized collection protocol. Quality assurance procedure, that you have some QC to ensure that it is at least a tumor or at least a normal. Integrity of molecular extracts, we decided that this put as optional because it's too expensive for all biobanks to follow. And finally, there must be a SOP, a standardized procedure for tissue access and protocol. So this is the requirement. Now, a kind of SOP is a variable, and I won't spend time to showing you what the SOP procedure is like. But as morning we heard from Dr. Zhong, it covers the sort of all the elements needed in your biobank, and here is human tissue biobank. We have got policies. Policies are all these things. What is a policy about withdrawal of samples and biobanking and all that? By the way, you can look at it. No point copying it because it must be different for different biobank. But you can use it as a guide to devise your own. And I'll be happy in ANRC to help you to devise your own as well. And then we have got these appendices, which are the paperwork. Now, to be useful, you need to have as specific as possible. So therefore, policies, you've got purpose, you've got procedures, it has to be very practical. And also we have all kinds of documentation, the kind of forms, so that all your staff are using the right template. You cannot have one person do it this way, another person do it this way, one person include the date, another person doesn't include the date. So you need to have some standardization, and this is one way you can do that. And we published this online in the past, but now they have taken it offline. So what I have shared with you is something we have made public. There's no secret here, but this is an old copy. New copy, now the institutions, they don't put it online for various reasons. But I feel it's great to put this all online. Next, so we basically says, does your biobank have a written SOP, a policy document that satisfies the grid standards? And we published it online in the past, and we put this here. Different countries, some are published online, some are not published. Some are in the vernacular language in Korean, Japan, Chinese. Not that helpful for those of us in other countries to use as examples. I believe in NRC we try to make it as possible in English as possible. Korea now has got an English version which you can use to share with other people. Now, as we analyze the question I want to ask is, what's the purpose of tissue biobank? So far, I still haven't answered the question of how to make a tissue bank financially viable. We mentioned what we can do as a stopgap. Provide tissue research services is one way. Don't waste. Don't collect things that you're not going to use is another way. You charge logically to ensure that your aims are met. You don't charge just to recover costs. You will never be able to do that. But I might charge to reward those who are very productive in research, and I will charge to penalize those who just collect samples and never use. So if there are no publications, I will charge a lot more, and I try to discourage them from using a valuable sample. So those are things that we can do to try to achieve the purpose of the biobank. But what is the purpose of biobank? Well, we have to say obviously is to facilitate biomedical research. Does it? Let me share with you this. We have this problem that in many biobanks, we have multiple researchers requesting for the same tissue for the same assay. It's a waste. Second, the data is not shared. You do next-gen sequencing, after all that data has been generated and published, it's gone. It's wasted. It's not reused by anybody. This is a huge waste of available resource. There's very little annotated data that's associated tissue. The tissue has some data, some specimen data, diagnosis. But all the next-gen sequencing data, transcriptomics that people use, after you've done the research, is gone. It's not attached to it. I think that is valuable. It's almost criminal not to use that data. And I shared with you what we do. We make it a requirement for people to share their data fields to make sure that we have better use of that data. But even then, it is difficult because there are people who do not want to publish the data for a long time, and we don't have access to the material. And there are people who say that it's competitive. Therefore, if I share it, other people may know what I'm doing. Even though I'm not giving the data, by sharing you my data fields, other people have an idea of my research direction, and they can use my idea. So they are not very willing. We have this problem too. So how do we overcome this problem? You see, because of all these constraints, the problem is that we have a lot of valuable patient samples which are locked away in tissue banks because researchers cannot afford them, or because the data, the value in the tissue is not the tissue itself, it's all the data inside the tissue, the molecular data and all sorts of clinical data that has to be unlocked. If you keep them in the tissue bank, they have no use. We must unlock the value in the human tissue. Is funding from commercial partners the answer? I would say that yes, there are commercial biobankers who will pay to get your tissues, but I don't think that is the full value. That's not the answer for academic tissue bank. We are not existing to earn money. We are trying to advance knowledge. Is there a need for a change in paradigm? And this is what I'm going to end up with. We are proposing, and I shared this at the last ANRC meeting, that we may need a paradigm shift to move away from tissue banks to data banks. And the idea here is we have now entered into a collaboration with Induvimab. It was published in the newspaper recently. Induvimab is a company. They function as a tissue bank. It's a German tissue bank. But this is a bit different from many other biobanks. because this tissue bank is interested in unlocking the value of the tissue. So what we do with this tissue bank is not to collect tissue and give to them. And I made it very clear. If you want me to just collect tissue and give to you, I'm not interested. But what they will do is to generate the data from the tissue. So this is the collaboration we have with them. In this collaboration, we will collect the samples. IndiviMed provides the funding, the expertise, the SOP for collecting samples to higher standards that meets the requirements, our standard. They inspected us and they felt that our biobank's standard is equivalent, so they are willing to work with us. So we will collect samples according to that standard that they have set. We will extract omics data. We will perform next-gen sequencing. We will provide transcriptomics. We will provide proteomics data, phosphoproteomics data. We'll extract all that data from the samples. We'll perform immunohistochemistry, immunofluorescence, multi-label immunofluorescence. We will do all of that and store that data in that tissue bank. They are a company. They of course want to earn money, but they will sell the data to the biobanks, to the pharmaceutical company. We, the contributors, will get the data for free. So in other words, in so doing, I'm not giving them any tissue. Anyway, it's against the law to do so. We are generating data from those tissues. All the tissues remain in Singapore. We will extract the data, and the data can be used by IndiviMed, who funded the generation of data for their commercial customers. We get the data for free for academic purposes. And this data is part of a big global database they are setting up with samples from all over the world. They have got centers in Europe, in US, in Asia, in Singapore is where we perform the omics data. They have centers in India that collect the samples, but we will generate the data. So this is the value proposition that we have. We'll perform these investigations on these samples to provide the data, which is what really researchers need. As long as this is done in a standardized procedure to the highest standard, researchers will be able to access, because what researchers want really is not the tissues, it's the data. So as I mentioned, this is the partnership. Through this partnership, the researchers our researchers and our biobanks get the data. IndiviMed gets the data that they can sell because they are there's a business company as well. But I think it's also done in a way that is ethically and legally permitted in Singapore, because we are not selling any tissues, only data is sold. So legally, not an issue. Ethically, somebody asked me about mutual benefits. This is the way we feel that has mutual benefits, because the hospital has benefit. Yes, the funding agency, the IndiviMed, has benefit, but the greater benefit to the public is that we have a way of unlocking the data in the samples. I think it's criminal that patients donate samples to us and 90% are not used because we cannot afford to perform next-gen sequencing and all that data from all those samples. No researcher can do that. So with this, my proposal is that the tissue bank will now change from being a bank of tissues to a bank of data collected from the tissues. And this is the message which I'm propagating also this year at the ISBA meeting in Shanghai, which I'll be sharing. And it's an idea which I'd like to share with you, that maybe this is something that we want to move towards. And there's a way that ensures our biobank will be viable, financially sustainable. More importantly, that it will serve its purpose to advance science and benefit the donors who have contributed their tissues. So with that, I thank you very much.
Thank you very much, Dr. Soo Yong. And so we can understand the talk very clearly with the ethical concerns and law and regulations about the tissue biobank. So does anyone has questions for Dr. Soo?
So microorganism sample that are not contaminated, that infection diseases like contain viruses or bacteria, and does the regulation in your country like include the microorganism as part of the tissue? Do you treat them the same or just isolate and do whatever you want without any regulations?
First, I'll say that you're absolutely right. Not just doctors in their own biobanks, but I think that the ATCC has mentioned that up to 40% of their original samples in ATCC, cell line samples, were contaminated with mycoplasma, various things, and or are not what they say they were when they've done an STR analysis. So that is really a concern. Now, with regard to the law, this law regulates only human tissues, so it does not cover microbes. Although we did have a discussion about what about microbes, there are a lot of people interested in the metabiome, so microbes taken from human persons. The law basically only covers the human tissue, so the microorganisms coming up from the gut does not come under the law. The law also covers more on the ethical aspect to make sure to protect patient interests. The law is not there to ensure that our biobanks are of good scientific value. That's not the purpose of the law. I think for that, you require a different mechanism, things like the BRIF and so on and so forth. So the law is not there to ensure the quality of the biobank, but is there primarily to protect the interests of the patients. But that being said, I think that is absolutely important that if the government is going to invest or any funding agency is going to invest in a biobank, you want to make sure that the samples that are collected are of good quality. And I've been arguing for many years that, number one, government agencies should not give any money to biobanks unless they have got good procedures in place and can prove that they have got good quality. But more important than that is that we, as a body in ISPA, ANRC, has been saying that really the people we want to get on board are the editors of the scientific journals. If the editors of the scientific journals will not accept any paper where the publication is derived from samples from biobanks that are not recognized, then there will be a need to push up the standard of biobanks. Now, in microorganisms already you have that. In cells and many other places, they already made the requirement. Microorganisms have gone way ahead of us. That if you do not, your samples are not collected according to certain standards, I understand that certain journals will not accept those publications. Human tissues has not come to that stage yet, but we are hoping that will happen. Now, when we work with the ISO 3C276, Singapore is one of the participating countries. One of the things we did consider is whether we're going to say that if your biobank is not certified to ISO, then the journals will not accept their samples. But I don't think that will happen because the ISO is far too expensive, and if you do that, you will kill off academic research. However, what will probably happen is that the biopharma for clinical trials, they may require the biobanks that support biopharma in clinical trials be ISO certified. But for academic research, probably not. However, I'm hoping that the editors of journals, nature journals, and we've spoken to some of them, we hope that they will require biobanks who submit samples to such top journals that they should be at least CAP accredited or accredited by or have at least certification by CTR, NET or something like that to raise the standard a little bit slowly. But yet not so expensive. I think ISO is going to be very difficult because it's far too expensive. Just downloading that document is $136. I mean, that kind of price. It's not going to be very useful for academic biobanks. So I can't see that as a standard. We need to change to a different standard. I'm hoping that the CTR net certification is sort of a standard that we can go by. It's not perfect, but at least a step in a better direction. I hope I answered that, yeah.
Thank you. I think I have one more question. Right now, a lot of different countries using the microbiomes, like taking microorganism, from one person and to treat patient, like, and also there are like bank that store like human poop. Yes, and do you consider this is the new thing that the doctors and also have to concern in the future? Like now you collect tissue, later you may have to collect something else that you used to actually treat patients.
That might happen. Certainly when you talk about poo, don't laugh because people have treated patients using extracts taken from poo. It's very well known that the microbiome in the gut has a lot to play with health and disease. And by changing the microbiome, you can actually treat patients. It sounds yucky, but actually from ancient times, it has been documented that that works. In fact, I think there's Chinese literature, ancient Chinese medical literature that suggests that for persons with a particular kind of digestive diseases, one of the solution is actually to take the extracts from the poo from a normal person. That might happen because the microbiome, you modify the microbiome, it does may have an effect. So I wouldn't be surprised that already people are already collecting such extracts. The problem right now is the science is not advanced enough. We are not so very clear how should it be collected, what's the QC issues and so on and so forth. But yes, they are starting to be collected. This is an area currently that's not covered by our law. Because as I mentioned, urine, feces, they are not covered, they are not considered human tissues. So they are not covered by our law, they are considered to waste. But the time will come when people recognize that they are valuable, and then you may have to consider a little bit from these, and there'll be IP issues and others associated with that. So yes, in time to come, I think that's, I won't be surprised, more and more people will be collecting these. In terms of the ethical and legal questions relating to these material, it's a bit less because meaning to say that it is not intrusive. These are basically products, waste products in general. It does not require you to perform a procedure to get these samples. That is not much an issue. However, if you are going to perform an endoscopy in order to sample the biome from a certain location, then of course all the other considerations will apply, whether there's a risk to the patient and consent and all this will come to play. But if you're talking about poo or urine, perhaps not so much. And yes, we have been requested to collect store urine, poo, thankfully not yet. Bowel, yes, we have been collecting bowel. Synovial fluid, rheumatoid arthritis patients, we have been collecting. So yes, there's already collection of such samples. But always be careful, all these are scheduled collection. Meaning to say you have a research project, you're funded, I'll collect. I'm not going to collect whole fridge full of poo for people that will never use it. You just don't have that kind of money to do that. Yeah.
Other questions? Okay. Thank you very much, Dr. Soo Yong. And now also we have a bit of time, or so we have a chance to get to know us a little bit. Does anyone have question or issues that you still have? Okay, Dr. Soo Yong.
As from a chairman of the ANRC Biobanking Committee, let me ask a little survey from those of you here. How many come from collect human tissues for tissue biobank? Oh, there are only one here, so there's not that many. So they're from Thailand. So the same question here: are your samples available for sharing with researchers outside of the institution, within Thailand or outside of Thailand? What is your practice?
Vice Dean for Research Affairs, Faculty of Medicine, Konkan University. I have two positions. I'm the researcher, and I have the collection of the biobank money. about the not the tissue bank because I collect the stool, the blood, and for the my researcher for my research, and I give some sample for my colleagues, okay, but not other institute, okay. The second part is because I'm Dean, so I established the biobank in the Faculty of Medicine and collaborate with the university. Okay, so now we establish the biobank and collect ask for free of charge for available for the researcher, and now we have the customer, the researcher that collect the tissue, brain tissue or some from maybe for big project, kidney disease and brain tumor and maybe the another tumor and bacteria resistant. So from my faculty, I have the problems. After I listen from your talk, I'm very, I think maybe global data bank that maybe paradigm shift from the biobank, and I think I will still going on or stop here because you said that it make a lot of money. And even the faculty ask for the researcher, this is free of charge, you can collect it for more than 10 years or something, but only some people give or storage the tissue bank. So I think the problem is because of the owner feeling and don't want to have the competition of the researcher to share the biospecimen. Even I don't collect the data, clinical data. Okay. Yeah. So just collect the biospecimen, but only some researcher be the customer. So how can we going on also?
Yeah, I think that's important, and perhaps if I've done my job today is to ensure that we think through the whole idea, because if you want to do something, you want to do it well. If you're going to invest money to collect some samples that has not supported by clinical data, that is not a standardized collection and so on, and in the end people do not want to use it or find it not very valuable, then all the investment is wasted. So perhaps you have to seriously think through what we want to do. It's a good thing to have biobanking, but you have to realize why we want to do it, and if you want to do it, you have to do it well. It's better to have a small collection well collected than for a large collection that's poorly collected. So, if we don't have enough money and so on and so forth, maybe we start small. Focus on what you can do well, rather than try to do a lot and then realize that it's done badly. I think that will probably advise. If you're interested in biobanking, do participate in the ANRC activities. This is a regional group meetings this year. It's going to be in the Philippines, I think. So, and for the Human Tissue Biobanking Committee, we will organize activities this year. We will, every year we talk about different aspects, but always we provide help to biobanks who want to start a biobank. And we will be happy to assist you as you think through what you need and what should be considered, even in terms of protocols, SOPs. But I think that today I have summarized 6 hours of talk into this period, 3 hours, to give you some background as to what you need to be thinking about going forward if you want to do. So if you're interested in biobanking, please join the ANRC and participate in our activities.
But I have some information to share. Before I have setting up the biobank, I make the virtual biobank. This means that I give some collection programs that available for the faculty staff to have the programs, and they collect and keep by the owner. So it has two systems. So I think because we have two systems, they can collect by themselves, but not without the regulation. Okay, just put in the freezer and record in the programs. So this is some problem that why they don't to correct in the central biobank. Yeah.
For me, the biobank of my department is just a small scale of biobanking because we just do like a project-based biobanking. We start with forming a teamwork, and we found that gynecologic pathologist is the best teamwork in our department. So we start with the gynecologic specimen, and we collect tissue, we collect urine, and we collect blood. It's now like about 1,000 samples, and we collect it, we use it ourselves, we publish it ourselves, and now we want to expand to other type of cancer like lung cancer. And for your presentation today, I think it's very informative. It cover everything. I have more than 10 questions, and you just answered it. Thank you very much.
I have a question for the countries here. Does any of the countries have law, legislation that covers biobanking like what we have? Yeah.
Thank you. You turn to me. I will explain because in our country we try to initiate or establish water bioresource center for I think more than 20 years. But it's the problem that because we cannot collect like the specimen or like the cell stain or like the virus bacteria from the hospital because we have no law. We don't have law. Then when we attend the ANRC, that's the first time in Japan. At that time, when I came back, I just talk in this what we need to have the law. Because when I heard about Vietnam, they have the law only in 1 year. They can collect the specimen like biocell and biomicro and many things. That's I think is we need to use because researcher, like you said, they think that it is the owner. They don't think that is the treasure of the country. Then it means that we need to try this, and for all of your country like Japan, Korea, and Singapore, I think you have many procedure that Thailand need to learn and follow. But I think that from the TBRC, Dr. Lily, she helps a lot, and the team also. I very much appreciate it. And I sent to the line group already. That I very much appreciated that I asked this team to help us because nobody, no organization to answer for when we have like the National Vaccine Committee and we talk about this topic. Ministry of Education, Ministry of Science and Technology, nobody reply yes. It's my duty. It's my responsibility. No, nobody. Then why NVI or National Vaccine still need to move forward for this and drive for the policy because we know that it's very important for the bioresource. And for the tomorrow. We think we will talk and to be like to talk for the in our country what we can go on. It's not withdraw or throw away. We will carry on, go on. because we think we invest a lot and we would like to have Thailand should have like the National Bioresource Center and for the regulation is under the medical for the human tissue is under or microorganism for the disease or like the emerging disease or something like the disease infectious disease is under the Department of Medical Science. That's as well, Dr. Sulapon and the others. We call it National Institute of Health. They are responsible for this, and now they have like a blueprint to construct like the bioresource center in the MOPH, maybe in one province. Tomorrow they will visit the area. Yeah, the area where which one is appropriate to do like the center. And for that you say that for 3 countries, you have the government support. Yes, it truly because you need to maintain. And liquid nitrogen you need to use refrigerator and many things to keep for the quality, and you need to check like the sequencing and many things. But I have the question for the Korea and the Japan. Yeah, Korea and Japan, because when we follow from Singapore, it's obviously that they have the system regulation. And how about for the biobanks in the Korea and Japan? Do you have like this? You have the short time only 30 minutes, but I remember you have short time, and Japan about the quality system is excellent. Yes, please tell us what you think is you have that is different from Singapore, or the same, or
maybe I can talk about the
micro.
issue.
Yeah, okay, you can chat because we don't have anything.
Anything, yes. Many things. Because okay. Recently, the Japan also we are focusing to big data, right here, and also the biobanking field also. Sometimes, of course, difficult to maintain tissue cultures. So, and the fast. Much more easier to exchange about data. So, and then the Japanese government also think about in the past, we will share the data, human genomes. Also, maybe you know well, in Japan, the biggest human bank is in Tohoku University, government university. In there, so many big servers there. In there is so much cohort research was done in there, because after these big earthquakes at the time, they give the one of the purpose is to share the human health. Yeah. So, and then gather the many data, and also the volunteer come every day to the hospital. So, and then there is a special sampling place. In there, so many people are working, and also there is a branch in the countryside also. And the data is come here, but very difficult to distribute to the researchers. So, and then first I heard that now almost the budget, of course, but budget is competitive research budget, so and not continuously. Then recently I heard that the facility will be shared with all of the tissue biobanking. So, and then all of the data, not only genome data or not only human genome, and other metabolic data and sample information, everything gathered to such a big database in the sub, because the facility is too huge. The facility are there. So I think that is I know that field. And also in other side, microorganisms, right? Of course, in Japan, microbiome, not only human microbiome. But first, we are focused and we are very interested about human microbes. Recently, the microbiome in the environment also become exciting now. It's a research. So, and then also in our culture collection, in our biobank, also we are thinking that not only for distribute pure microorganisms. Now I already talked with Lily. We start to distribute a mixed culture, and with information or something like that. So maybe also a little bit different, but the microbial biobank should think about the purpose. What he said, what you want to do, what we want to do. I think so, and I want to
I want to support the company to research microbiome so that we make a mixed culture. But the quality is high quality. Also, we spend yes much how to say the power to make a good one or something like that. Maybe I'm sorry, it's not just.
Interesting. May I ask you, how can you can announce for the volunteer to come to the institute or Tokyo University?
No. That was in Japan. So many research group was there because somewhere very interestingly.
So announcement in the trains.
Yes, you can see on the website. But very interestingly, in some prefecture, some countryside, the average of age is lower than average of Japan. You know, the Japanese people can read very long, but some part is very low. So
This is like in Tohoku.
Tohoku, one part, not Tohoku, Aomori. Yes, one of the Tohoku area. So maybe very food is very salty.
What is the reward for volunteer? No reward.
Well, because the government, local government support because this is a health check, health support. So, and then give some exercise also, and then take sample, and then it's good.
Very good idea.
I'm sorry, I'm not familiar.
This is the first time
มันขึ้นกับ culture ของคนด้วยนะจ๊ะเนี่ยของคนแต่ละประเทศ
Korea. Sharing.
Ajarya. I'm a member of the microbiome bank, so I'm not sure that the exact situation of the human-to-living materials in Korea. But Korea has national laws related the ethic and the human-to-live the biobank. So the Ministry of the Health maybe it has assigned some core hospital related to the laboratory for the collecting the human-to-live the materials. Maybe 4 ifs, yes, the project that they continued, and they also collected the material and the related data, and then the constructed databases. I know. And the related to the gut microbiome as and now I'm constructing the Korean gut microbiome bank. So it's just the focus on the anaerobic bacteria from the gut microbiome, and then it's just maybe 3 years this year. This is the 3 years, and I collected more than 6,000 strains that belong to the more than 300 species. Now we collected our focus is to the health people in Korea. So the first stage we focused healthy adult, Korean adult. And we collaborated with the hospital, and then we collected the fecal samples from the healthy Korean adult. And then we get the fecal on the condition of the anaerobic conditions with the pouch, and then the hospital sent their samples to my laboratory, and then the collaborative lab. The collaborative lab is analyzed metagenome analysis and the functional analysis with the whole genome basis, and our team is isolated the absolute anaerobic bacteria, and then we also identify, and then we perform some original sequencing for some strains,
And then we also analyzed some metabolic analysis, and then we now constructing the whole databases related the clinical data and the metagenomic data and the isolated bacterial data.
I just want to update to you because actually I should have said this since morning, but I forgot. There are two things that I want to update to you on the condition of Thailand, because it's like as Dr. Anjali mentioned that we try to centralize it a little bit by the Ministry of Public Health, but it's impossible because of the budget. So since then we discussed and then we formed like a network of the biomedical, and that's how we come up with like how we going to do it like step by step. So what we do right now is to how to say that like maybe form like a network and then not to educate but like try to make sure that all the data, all the cultural collection or the biobank, medical biobank has a proper way to store their information by using the software. Like Dr. Piupan just mentioned, she also do that with the University, Khon University. So she has her own data format. But we also provide our software to help with the other university that might not have the data. And hopefully with this software we call iCollect, that could also facilitate the network as well, because but first of all, it's customizable, so it can be used with tissue, with blood, with anything. And second is like it allows all the collection to be linked by using this feature of the software. So eventually, if we want to, we could have the hub of these biomedical resources in Thailand. It's kind of virtual. We don't have, and the sample will be stored with the experts in the countries. That's probably our goal in the NVI, right? And secondly, with the together with NVI, we will probably host the ANRSC in 2020, I think, because this year we'll be in Philippines and next year we'll be in Thailand together with NVI. So of course those experts from university will be invited, and they will probably join your biobank session as well. So that's the two things that we want to update. Thank you. Thank you, Dr. Lily. More comments or questions?
I'm from the Faculty of Veterinary Science from Prince of Songkla University. Because I'm from the veterinary, so almost collect about the sample from human and microbiome, and how about the animal? It should collect or not? Do you have experience in Singapore or any?
Very limited experience. Singapore is not agricultural country, no agriculture at all. But we have quite a lot of animals in terms of dogs and cats, pets. As I mentioned, I wear many hats, and one of my hats is as the head of a laboratory that takes care of veterinary pathology. So I have two veterinary pathologists working on me. One working on GLP toxicology. We use rodents and other animals for toxicology work for submission to FDA, and another branch is to provide diagnostic veterinary pathology services for our veterinary hospitals, clinics in Singapore, and we serve most of the veterinary clinics in Singapore. And as I mentioned, that's not too long ago, I just diagnosed a large B-cell lymphoma in a dog, mediastinal FNAC. So because of that, we do collect some of these animal tumor tissues. And the purpose why we do that for two reasons. Not so much for research in veterinary pathology, to some extent it is that, but mainly because I'm thinking of developing AI diagnosis for veterinary pathology. It's hard to find veterinary pathologists, and AI of course has moved such a stage that we can actually use artificial intelligence to make diagnosis to help the veterinary pathologists screen through cases of tumors in dogs and cats, and this is one area we do. So we do collect samples mainly paraffin embedded material for this purpose. Is there a place for biobanking or veterinary pathology samples? Yes, there was some interest. It's limited, but there's some interest in that biopharmaceutical companies are not just developing drugs for humans, but they're also developing drugs for animals. And so there is an interest in looking at some of these therapeutics for animal therapeutics. And so there's a demand for this work. In fact, it's very interesting. We are in the process also trying to develop xenograft models from dog tumors, putting it into some other animals. And the idea here is that we're going to treat these rodents with, they carry the dog and tumors, and with different kind of drugs to see which one responds better. And this is an area that's in a way easier than human, because human clinical trials are very expensive and a lot of regulations. Animal clinical trials very much less expensive and the regulations are less stringent. And many drugs that failed human clinical trials may be actually suitable for animals, because a drug that gives rise to long-term risk of cardiac failure in a human after 20 years may not be suitable for humans, but the dogs don't live 20 years, so therefore that drug may be suitable for the dogs. So these are things that increasingly the people are talking about, and so there may be a case for such biobanks as well to serve the veterinary pathology market, and that some companies, some biotech companies are actually interested in this area. Yeah.
Thank you very much. And I got one idea, that's for collect the tissue sample, and maybe we can sell for the tissue like a slide and stain with many staining, specialized staining.
Yeah.
And because that's for the veterinary science,
Yes.
I can make that.
You can certainly do that. In fact, we are also making tissue arrays of tumors from dogs and cats for the purpose of for pharmaceutical companies who are interested in bioequivalent studies. They actually have they need to test and see whether these drugs have